Hello, hello, my friends. Here, hold on one sec. Jill Osborne from the IC Network. A little bit late this morning. Sorry about that. Been a very, very busy morning for me. All right, hold on one sec. I gotta get myself together here. Oh, wait a second. There we go. There we go. All righty. I'm going to do some sound checks and people come in. All right. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, March 8th of 2026, and it is time for another live IC support group meeting. Hello, Mr. A. Hello, Cher. Nice to see you. Right now, we are streaming on two platforms. We are streaming on YouTube and we are streaming on Facebook. And I apologize for being a few minutes late. It's just been a very, very, very busy morning for me, my friends. Very busy morning. Plus, throw in, daylight savings time and all that sort of stuff. The gorgeous day here in California. Gorgeous, gorgeous day. I don't know about you, but I am so over winter. I am ready for sunshine. Hello, Facebook. So let's just wait a few moments for some people to come in. Hello, 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 my friend. So I have got news. I've got news, incredibly frustrating news. Hold on one sec. Okay, that's one of them. And this is another one. And let's just say I really got my geek on this week, and I was diving into reading all the filings in the Elmeron lawsuits and trying to figure out where we were. We had our big meeting with a big Zoom meeting with patients who are struggling with retinal damage, et cetera, and inflammatory bowel disease. All right, one more paper. Here it is. Here it is. Okay, I am now organized. Sorry about that. Sorry about that. All right, so let me introduce myself. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I am an IC support group leader. I am the longest serving, IC support group leader in the world at this point in time at 33 years and counting. Let me tell you, when people tell me no, I say, yes, I'm going to do it anyway. For those of you on Facebook, listen, I want to check your sound. How is your sound on Facebook? Because you had an echo. I switched mics around. That's why I was a little slow. I was switching microphones. And for those of you on YouTube, how is your sound? Everybody, if you can just check in on your sound, that would be great. I'd really appreciate it if you could let me know, because I'm not sure about Facebook, to be quite honest. Here, hold on. I can see a few people in here, but I need you to tell me if the sound is okay. Hello, Facebook. Sounds good. Okay. We're good on YouTube, because YouTube, you're on the big microphone. Facebook is on the small microphone. So Facebook, for anybody in here on Facebook right now, could you please tell me how the sound is? Is the sound okay? Testing 1, 2, 3, Facebook. Excellent. Thank you, Phyllis. Thank you so much. Excellent. That's what I needed to know, because I'm an IC support group leader. I am not a tech guru. Thank you, Lori. Thank you very, 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 very much. Okay, my friends. My purpose in doing these support group meetings is to educate you, to empower you, to give you perhaps a new perspective on looking at your symptoms, especially if you're not responding to the therapies you're doing. My job is to kind of open some windows, open the doors, then give you what you need to go back to your doctor to ask perhaps some more important questions, more effective questions about finding the right treatment for you. You have to remember that today we no longer think of IC as an incurable bladder disease. Today we think of IC as a pelvic pain syndrome for which there are many potential causes and triggers. And so rather than telling you you have an incurable bladder disease, giving you an antidepressant and the IC diet and perhaps Elmeron and sending you on your way, we're not supposed to do that anymore. Our national guidelines are really clear. You're supposed to be phenotyped. We need to understand which variation of IC you have because we're not all the same. We're just not all the same. And, you know, it's so interesting. I work with patients every single day. I mean, I work with them on Saturdays. I work with you guys on Sundays. I take phone calls Monday through Friday. And I get many, many phone calls from patients who were diagnosed 5, 10, 15, 20 years ago. And literally, they've never gotten better. They've done every treatment that doctor has given them, and they have never gotten better. Their symptoms might have helped a little bit, but the problem is they're still flaring wickedly. Why? Well, if IC were a bladder disease, wouldn't bladder therapies help? And the answer is they don't help for most people. They didn't help with me. You got to remember, I had my first symptoms when I was 13 years old in junior high. I spent decades thinking I had a bladder disease. I did almost every treatment they gave me, including very painful urethral dilations, every oral med you could take, except thankfully I never took Elmeron because it didn't make sense to me even back then. But here's I had every bladder installation. I did neuromodulation, but guess what? I still suffered tremendously. Why? Well, in 2008, when we started learning about the role of the pelvic floor, I went, oh, wait a second, I better go check my muscles. And I went and checked my muscles. And you know what? My muscles were as hard as concrete. Whenever they looked at my bladder always looked fine. My bladder has never had redness. It has never had inflammation. It has never had ulcers, despite the fact that I was peeing every 15 minutes and crying my eyes out with pain. It would have been very hard to convince me I did not have a bladder disease, given the fact that I thought that I had a bladder disease and I was up all night crying. Okay. But it's an undeniable fact. My doctor showed me pictures of my bladder. My bladder was perfectly healthy. And what my doctor said to me, he said, Jill, this proves that this is really not a bladder disease for you. This is a neuromuscular issue. And when I started looking at it from that perspective, and when I started learning about the role of the muscles and nerves and how that can cause bladder symptoms, and most importantly, when I started physical therapy, guess what happened? I got better. And today in 2026, the single most important diagnostic test for you is, in fact, a pelvic floor assessment. Our national guidelines from the American Urology Association only have 2 recommendations. Recommendation number 1, if they think you have Hunner's lesions, like if you've got blood in your urine, if you've got agonizing pain, we definitely want to look in that bladder and make sure that you don't have lesions, because if you do, we want to treat them. And recommendation number 2 is if you've got tight pelvic floor muscles, you are to be referred immediately to pelvic floor physical therapy. Immediately. Why? Because pelvic floor physical therapy outperforms every other bladder therapy in research. And listen, you got to understand, my friend, there are all sorts of people online. There are all sorts of consultants. There are all sorts of companies who are saying, take my product. You're going to get better on my product. Sign up for my coaching program. You're going to get better on my coaching, my recovery program, all that sort of stuff. Don't fall into that until you learn about phenotyping. We have got to understand your underlying phenotype first. So as an example, I was working with a patient, spent a lot of time trying to learn how to do an elimination diet. And yet her bladder is perfectly healthy. They looked with a cystoscopy. Her bladder is perfectly healthy. There's nothing wrong with her bladder. Her muscles were horrifically tight, but she spent hundreds trying to learn how to do a diet that really, honestly, was rather pointless. So anyway, our goal here is to try to identify the underlying cause of your symptoms. And when we find the underlying cause of your symptoms based upon your phenotype, we can then talk about the correct treatments for your unique case of IC. Hello, Brandon. So hello, Phyllis. Hello, Lori. Hello, Judy. Hello, Brandon. Now, you guys on Facebook, my screen has frozen, as it is wont to do. And so I need you to tell me if you see a moving face. It's very common that this happens, but I just want to make sure Facebook is okay. So for those of you on Facebook, could you just let me know, is it okay or has it frozen? Here, hold on. Brandon says everything's fine. All right. All right. And we're going to say hi to, again, Mr. A and Cher and Boria. How am I feeling? I have Hunner's ulcers. She said, and Cher, hold on one sec. How am I feeling? My incisions are hurting like a bitch. I just have to tell you right now, I have neuropathy from my breast cancer incisions. It's been 18 months that I had surgery, and some days it's like I had it yesterday. But anyway, it is what it is. Generally, I'm feeling much better. I'm feeling much more energetic. I am feeling here. I am feeling connected. I am working. And most importantly, I'm so happy that it's sunny. You want to depress Jill Osborne, just surround me with fog and rain. Oh my God, I'm never going to be able to live in Seattle or Oregon. I need to be in the warm weather. But so thank you so much for asking. Cher says she has Hunner's lesions and 10 pinpoint hemorrhaging and bleeding. Okay, so Cher, you're going to fall into the Hunner's lesion phenotype. And so therapeutically, we're going to look at treatments that have the potential of reducing those lesions, which is going to be a steroid injection into the center of the lesion. They might choose to cauterize the lesion. And of course, now we have Lactoferrin, which the IC research study that was exactly a year and a half ago showed that red inflamed bladders became pink and healthy. And there are a couple of other things now that we're looking at with patients who have Hunner's lesions. We're looking at very, very inflamed nerves as a source of the lesion. We're looking at posterior fornix syndrome, which is a damaged ligament, as a source for those lesions. And of course, we're now looking at viral infection as the source of those lesions too. But if you haven't tried the Lactoferrin, that would be like one of the first things you could try. So I had a mother call me whose daughter, her 12-year-old daughter, had 15 Hunner's lesions. That is crazy. That poor daughter's bladder was filled with bleeding wounds. And I honestly have never heard of a young child having so many Hunner's lesions. And I asked her as we were talking about it, because it's just so incredibly unusual. I said, by any chance, has there been any exposure of mononucleosis in your home, Epstein-Barr in your home? And she kind of gasped. And she went, yeah, her sister had very severe mononucleosis 6 months ago, and they share a bedroom. Now, this is huge because we have now connected the mononucleosis virus, the Epstein-Barr virus. We have found that in the urine of patients with Hunner's lesions. And when I say we, I mean the U.S. government. The National Institutes of Health has actually found virus in about 5% of IC patients. Generally, there are two viruses: the Epstein-Barr virus, the Epstein-Barr virus, and/or the polyoma virus. And so in the case of this poor 12-year-old, she had very severe mono in her bedroom. Clearly it infected her, and clearly it reached her bladder. You know, and that's the thing with viral infections. That can happen. That can really happen. Cookie says she'd like to hear about Bladder Builder. Oh, well, listen, I have news, and you guys, I have to talk to you about something very, very serious. But let me just answer this question. Okay. So just so you know, here's the old Bladder Builder. Here's the new Bladder Builder. Same product, new, better label. We just got our shipment in. And so if you're looking for Bladder Builder, it's in the IC Network shop. Bladder Builder is, in fact, what I think is the best supplement on the market today. It's got the best reviews on Amazon, like 4.7 stars, something like that. It has a couple of different methods of action. It's got chondroitin to support the bladder wall. It has quercetin as an antihistamine. It's got some beneficial probiotics for the gut, but most importantly, it has palmitoyl ethanolamide, also known as PEA, to reduce pain. So it has multiple methods of action. So what makes it better than the other supplements is that the PEA, the palmitoyl ethanolamide, calms nerves down. So it was released, I want to say, in 2020. We did a follow-up study after it had been out for about 9 months. We went back and surveyed patients who were trying it. They reported fewer flares, less painful flares, and a dramatic reduction in their pain. 60% of the patients who tried it. So certainly not everybody, but a good chunk of patients responded well to Bladder Builder. And the thing here is, Cookie, it's not just the cost of the Elmeron. I mean, it's the devastating side effects of the Elmeron now. The fact that Elmeron can lead to retinal damage and blindness, and Elmeron can lead to inflammatory bowel disease and needing to have the bowel removed. So patients, 10 years ago, were transitioning off because of the cost. Now people are transitioning off because they want to save their eyesight. Let's talk about that for a moment. Okay, so in my little intro that I wrote for this meeting, I said we have disturbing new news about maculopathy. And it is in the form of a couple of different studies. This study, which was published last year, and this was published by the eye researchers at Emory. And then we have another study. So the assumption here was that the longer you used Elmeron, the greater the risk of eye damage. And what this study found is, here, hold on. I think if I remember correctly, if you consume between 599 grams of Elmeron, you had a 12% risk of developing eye issues, the pigmentary maculopathy, and potentially retinal atrophy. It's pretty serious, very serious. If you took between 1,000 and 1,500 grams, you had a 30% risk of developing eye issues. And if you took over 1,500 grams, you had a 42% risk of eye issues. And it's really what we call a dose-response relationship. The more you take, the greater the risk. Okay? But here's the thing that I found particularly shocking. So in this study, so remember, everybody's been talking about oral Elmeron. And the assumption was back in 2022, 2021, 2020, when we first started learning about this, that having a bladder installation was a safer way to use Elmeron that appeared to reduce the risk of eye issues. In this study, they have a patient who only received Elmeron via a bladder installation. And let's see, at a cumulative exposure of 5,800 milligrams, this is the lowest known exposure for Pitocin toxicity. So this patient who never took it by mouth, who had it as a bladder installation, developed retinal damage. Okay, that is just shocking. I don't know about you, but that stuns me. Oh, and it gets worse. Hold on. Here's another paper. And this paper was published last month in the Journal of Ophthalmology. And so I didn't really know this, but it turns out they are injecting Elmeron subcutaneously into for arthritis. I don't want to say into joints. I don't think it's into joints. Subcutaneous administration of Pitocin polysulfate for the treatment of arthritis. And so this was a multi-institutional retrospective case study that examined 3 cases, 3 patients who developed retinal damage after an Elmeron injection for arthritis. One in Miami, one in Los Angeles, and one in Sydney, Australia. This is between September 1st, 2024 and July 8th, 2025. 3 patients with Pitocin maculopathy presented following treatment for osteoarthritis or inflammatory arthritis. The cumulative dose was very low in all 3 cases and ranged from 45.5 to 96 grams during a span of 7 to 10 years. The multimodal features in all 3 cases were classic to Pitocin retinal toxic effects. The findings of this case series suggest that Pitocin retinal toxic effects can occur with subcutaneous administration alone at much lower doses than typically occurs with oral administration, potentially due to the 10-fold higher bioavailability. Early recognition of this toxic maculopathy with multimodal imaging is important to limit exposure. Given the progression of maculopathy, even after cessation, caution is advised. Now, of course, these researchers are saying, hey, we need to verify this with larger studies. Of course, they need to do that. But this is freaking disturbing. This is upsetting. It's upsetting. Okay, and then we have yet another study that was in January of 26. That was a study from China that evaluated all of the FDA adverse event reports on Pitocin in the U.S. by the U.S. FDA from 2004 to 2025. There were 11,471 reports of adverse events with Elmeron or Pitocin polysulfate as a primary suspected drug. The reporting frequency and strongest signals were overwhelmingly concentrated in the eye disorder symptom, with pigmentary maculopathy demonstrating an exceptionally high incidence. But significant non-ocular symptoms were also identified, including depression and anxiety. And what's interesting, they did a gender analysis that showed that women were more prone to maculopathy while men were more prone to GI problems. So, this 21-year real-world analysis confirms that safety signals for Pitocin polysulfate show a distinct long-latency risk profile, most critically vision-threatening maculopathy. The study highlights potential psychiatric adverse events not currently documented in the drug's label and reveals gender-specific risk profiles. I know y'all are getting real tired of hearing me talk about this. You got to understand, my friends, that many, many patients are suffering significantly. We had our meeting last week, and I had 22 people in the meeting. 8 had colectomies. Oh, that's the other paper. So remember, it was the eye researchers at Emory who brought our attention to the fact that it seemed like almost all the patients, or most of the patients who were suffering from eye issues, also had inflammatory bowel disease. And here we have another paper. This is calopathy associated with pentose polysulfate use. And there was a case study of, I think, an 89-year-old gentleman who had severe retinal atrophy. Here it is. Here's another paper, and this is from March of 26, so this month. An 86-year-old male presented with bilateral high in motion visual acuity and a 26 history of pentose use, 400 milligrams daily for the treatment of interstitial cystitis. Fundus exam revealed widespread retinal degeneration characterized by retinal atrophy. This case supports the dose-dependent nature of pentose toxicity and demonstrates that high cumulative doses can lead to widespread retinal degeneration beyond typical macular involvement. The potential severity of irreversible vision loss highlights the importance of periodic retinal evaluation. Yeah. Kim says, you've been taking it for 29 years. Hi, Tanya. Hi, Ann. Hello, Pamela. Hi, Darla. So, Donna, I agree. So we have a lot of comments coming in here. Kim, here's the thing. And this is what I say, because it's just shocking that it's still on the market, to be quite honest. I believe that it's shocking because the FDA denied its approval for 5 years, from 1991 through 1996, or just before 1996, when they submitted the application for Elmeron approval. The FDA denied it. And the reason they denied it is, as in their own words, the research that was presented showed that only one doctor had success with it, and that was the doctor who was involved with a patent. All the other doctors in those studies did not have good success with it. And so the FDA said, hey, listen, so what you're saying is only one doctor can use it safely. So what we'd like you to do is do another study without that doctor to really show us what it can do. And the company hemmed and hawed and hemmed and hawed. They didn't want to do it. They reevaluated the data, submitted it again. The FDA denied it again. They actually had meetings in which they talked about the design of the new clinical trial that they wanted, that involved multiple doctors, but again, without the patent holder. And then the company submitted some compassionate use data, and it got approved without that research. It took 18 years for that research study to be done, and that study was led by Curtis Nickel, one of the top IC doctors in the world, the top IC researcher in Canada. Very, very, very well-respected doctor. And they published their data in 2014, 18 years after it was approved, and guess what? It didn't work. It didn't work. It was no better than placebo, or very close to placebo. And there was this great investigative report done that was released a year ago, where they went back and they did Freedom of Information Act requests and looked at the entire FDA approval of this medication and others. And so they interviewed Curtis, and Curtis said he thought it'd be pulled from the market the next, very quickly. It wasn't. It's still out there. And there's still doctors that are telling patients this medication is safe. And what they say is, well, I've never seen eye issues in my clinic, therefore I think it's not that big of a deal. I think you should take it. You come to one of our support group meetings and you meet another patient who's going blind from this medication. They have a completely different take on this situation. And now we've got patients who not only are going blind, they've had to have their bowel removed. So, and that is an association that has been documented in multiple studies. But it's a lot harder, I think, to prove bowel issues than it is to prove eye issues. And so we're all waiting for more research, but the research right now is really quite compelling. Plus, they have the publication of several case studies of patients with severe bowel issues who, when they stopped the medication, the bowel healed and all their bowel problems stopped. I mean, if there was never a closer description of cause versus effect, it's those very simple case studies. A patient with very, very severe bowel symptoms, inflammatory bowel disease, who, once they stop the medication, their bowel heals. Hello, cause and effect, in my opinion. So Kim, Kim, what I would say to you is, number one, it's not just one research. We have a lot of research now. There is a black box warning on Elmeron now, warning people of the eye issues. And the longer you take it, the greater the risk. And it's also important for you to know that when you stop the medication, that doesn't mean the eye damage stops. And in fact, we now have multiple studies showing the eye damage progresses even after you stop the medication. And so our goal here is to protect your vision. And especially as we get older, often what somebody who's older needs the most is to be able to read and see, to occupy their time, and that's getting quite hard now for some, but certainly not all patients. There are some patients who use it who are not developing these issues. That is very, very true. But there are a number of patients who are getting these issues. Then the other thing I would just say to you is you got to remember that Elmeron is a coating. Pentosan is a coating. The early, in fact, I have it right here. I can give you an example. This is one of the early educational flashcards that they used to give out when Elmeron was first approved. And if we look at this, so here's a three-dimensional section of the bladder wall. And what the company was saying back then is that the bladder lining is missing or vulnerable. And so Elmeron acts to provide a coating. And this is straight from them. So Elmeron doesn't repair tissue. I do not believe that it repairs tissue. I believe that it protects tissue, which is why it would be helpful. I can understand why it would help, because it would cover up a very irritated bladder wall. It would, especially if you are an estrogen atrophy patient and you already have a thin gag layer anyway, a thinner protective coating anyway, and that's your phenotype, then doing something that will give your bladder a little bit of extra protection makes total sense. It's valid. It's a valid concept. But for somebody with estrogen atrophy, for example, what we're going to say is, okay, what can we do to help the skin start making its own coating so you don't have to take a coating? And that's topical estrogen. This is where we do topical estrogen. And most patients who transition away from the coating effect of Elmeron transition over to the coating effects of a chondroitin-based supplement like Bladder Builder or Bladder Rest or Cystoprotect. And they've been transitioning for years. And this is not new. I mean, Elmeron got so expensive years ago that many, many patients just couldn't afford it. It's actually talked about at the 2006 IC San Diego conference, because Dr. Parsons was a speaker and Dr. Theo Harides, the gentleman who invented Cystoprotect, they were on the stage together talking about it. They're both IC researchers. All right, so let me go back to your questions here. Hold on one sec. Now, here's my rule. Be the squeaky wheel. Do not be offended if I miss your question. Believe me, I miss a lot of questions. Don't take it personally. Just ask it again. And this is my policy for my phones when you're trying to reach me. You have my permission to call over and over until you get me. Because I get so distracted and I get so busy. I mean, I sincerely try to call everybody back. But, then the phone rings and then, we have a delivery. And anyway, so don't be offended. Just keep asking until you get satisfaction from me. Here, hold on. I got to clean my glasses here. A little bit on the dirty side. Okay, that's better. So let's go back here. So I'm going to go to YouTube first. Mr. A, do you know anything that might cause Trigonitis, inflammation of the bladder, neck in a young male? My urologist had no idea what could have caused it, as I've never had a UTI. Okay, so when I built the IC network years ago, and I was researching all the kind of related conditions that kind of mimicked IC, Trigonitis was one of them, and I distinctly remember reading a big section on men with Trigonitis, and they were talking about chemical irritants, if I remember correctly, such as a spermicide. Which, which is kind of a stretch, because you're like, yeah, well, how would the spermicide get up there? But, if you're having sex, and it's possible that some chemicals could pass up the urethra. I think it's a little bit of a stretch for a guy, but I distinctly remember reading that spermicides were an issue, that soaps were an issue, that the type of condom that you used could a big issue, especially if it was a latex condom, that there was some consideration that patients could be having a reaction to latex. What else did they talk about? Okay. Strong soaps, something really strong like Irish Spring, potential to be quite irritating. But it was really spermicides, condoms, bath soaps, laundry detergents, fabric softeners. And again, I understand it's like, how would that affect the trigone? But that was their guess back then. I would also be looking. So for anybody who doesn't know, the trigone is a triangular piece of tissue on the bladder wall. You got ureter, urethra. So it's a triangle, trigone. And this tissue in the trigone is very different than the rest of the bladder wall. It's a much more complex tissue. It's also much more estrogen dependent, especially in a woman. You have to explore the concept of, is this tissue being irritated with a chemical in some way? Because the bladder, like any other part of the body, can be injured. And generally it's injured through a toxic chemical exposure. So if, for example, you were drinking a lot of energy drinks, if you're drinking a lot of coffee, if you're drinking a lot of soda, that the residual acids and the really strong acids and the strong caffeine found in an energy drink really could cause a lot of widespread irritation, especially if you're doing a lot of it over time. So that would be my best guess. Mr. A said, I remember thinking, I'm not going to take Elmeron because I'd rather have IC and be able to see than have IC and be blind. Exactly. And the reason why I didn't take it, because I was a support group leader in '96 when it was approved, but I'm also a pharmacologist. My second degree is in drug development pharmacology. And as I was reading the science of Elmeron, my answer is, okay, it's a chemical Band-Aid. But if you swallowed a Band-Aid, would you expect it to come out the other end of Band-Aid? And the answer, of course, is no, we have digestion. And the bioavailability studies for Elmeron were really quite poor. The company, I think it was the researchers from Baker Norton, or it's the second company to own it, published a bioavailability study. What does that mean? What does bioavailability mean? What that means is, how much does a medication arrive where it's intended to go and functional? Is it functional? Is it able to do the job you hope it's going to do? But of course, when you swallow something, we have digestion. And digestion renders the bulk of many of the medications that we take completely ineffective. I mean, just breaks it down. It can't do the job. And so the bioavailability study of Elmeron that I remember reading showed a bioavailability, or showed that 93% of it, either 92 or 93% of it was destroyed by digestion. And so what that meant is that only 7% of it actually arrived in the 7 to 8% arrived in the bladder to be able to do the job they're saying it's doing, which is coating the bladder wall. And because that bioavailability was so low, you'd have to take a lot of it over time. And for me, I just, that just didn't resonate with me. And so I made the decision not to take it. All right, let me go back here. Okay, so you guys just know Facebook jumps around and I waited too long and I'm sorry. Lori says I'm moving. I'm moving? Well, I have a tremor. You know, when I get stressed, my head does this. So maybe that's what you see. My neck gets super tight and I get a tremor. Okay, so hold on a second. Pam says she's dehydrated and that's causing issues. New urologist says to drink more water. I drink more water than ever before. I have, hold on. I have blisters. Oh, God. Sorry. I'm sorry. Facebook just jumps and it makes it so hard for me to read it. It's not letting me click to read the rest of what you said. Darla said, I just went to a urologist who demanded that I go on Elmeron, said it was the only thing that helped me. Helped IC, and they laughed at me when I told her I was concerned about my eyes. And she said she's never had one patient who had eye problems. I think if I ever went back to her, she'd get an earful. Understand that the company has now paid the companies involved have so far paid $43 million to patients who were hurt, patients and their attorneys. Okay. If this were not a thing, they would never have paid that money. Okay. And I have that if you want to see the proof of that. I have this, which is the Special Masters Report and recommendation for the allocation and distribution of common benefit fees and expenses. And this came out last November 14th. And here it is. This is the list of all the money that's been paid so far. So, for example, the Seeger Weiss Law Firm has gotten more than $250,000. Douglas Linden got almost $250,000. Morgan & Morgan over $100,000. The total is, oh, I'm sorry. Actually, I was reading it wrong. Seeger Weiss got $10,676,000. Douglas and London got $7.5 million. Morgan & Morgan got $7.5 million. Lee and Pampantonio got $5 million. It just goes down. And then those smaller fees were just fees. Anyway, the total in this filing is $43,615,720.26. They start, see, the way a mass tort works, you know, you're thinking class action. It's kind of like a class action, but different. Basically, all the separate cases that have been filed in federal court get consolidated into one court. And in this case, it was the Federal Court of New Jersey. And so you've got a whole bunch of plaintiffs. I think that there were well, I don't remember the exact number, but there were hundreds and hundreds and hundreds of patients who sued. And so there were many, many law firms involved representing patients. And then there were a handful of law firms that were representing Teva and Janssen Pharmaceuticals. And so that court then works with basically a committee of attorneys to kind of move it along. And then those attorneys communicate to all the other attorneys. You can't have 50 attorneys trying to work with the court at the same time. Basically, in a case like this, eventually there is going to be what they call a science day. And a science day is when the plaintiffs and the defendants get together with the science, with the hard research. And I'm not sure if they have expert witnesses then or not. I kept looking for the report on Science Day in the filings. I spent a couple days going through all the filings through the PACER database last week. I couldn't find it because they kept pushing it back a couple of months at a time. But then suddenly in early 2022, and I can give you an exact quote here. Let me give you the exact quote. Hold on. Basically, the plaintiffs presented their case very well and convincingly on behalf of IC patients who were hurt, and the company started settling. Let me see if I can find that quote for you. So they started settling at the end. Here it is. It is clear that plaintiffs' leadership, under the direction of co-lead counsel and aided by the court, aggressively pursued and efficiently managed this litigation against Janssen and Teva, which led to a successful resolution, which included yet unfiled cases. The settlement discussions began in early 2022 with the resolution of the first cases in December 22, less than 2 years after the plaintiff's leadership was appointed. The settlement negotiations laid the groundwork for all the firms that pursued settlement in this multi-district litigation. Okay. Here, hold on one sec. Brandon said, Victoria says she was on it for 2 months and it saved my life. Well, I mean, I wouldn't worry so much about 2 months, but there are patients who report vision changes in the first year. And the thing is we don't have treatment there. I think there's only one published paper from years ago which suggested they might have a treatment for it. I haven't seen any current treatments for it, nor have I talked to any patients who have been diagnosed with this who have ever found an effective treatment. So this is when it happens and damages the retina, that damage appears to progress until atrophy occurs and vision becomes very limited. Larissa said, I've been having eye problems, went to the ophthalmologist this past Monday. I told him about IC and he took Elmeron for several years. He knew all about it. He marked it in my records to watch. You have several eye problems that you're still being tested for. There you go. Brandon said, what is the compounded Elmeron cream for? No, it's not Elmeron. It's a compounded estrogen cream, estradiol cream. A compounded estradiol cream is used topically to help that skin plump up and start producing more mucus. Victoria has been in remission since last September. Excellent. Really, really glad. Tanya said, having problems with estrase cream, the estradiol causes my breasts to be tender and bloat. Is there an estrogen cream weaker that may not give me the side effects? I do have atrophy and it does affect my bladder. Estrase is not that soothing. It must have some chemical ingredient. That is true. Estrase is a brand name. Both Estrase and Premarin, if I remember correctly, I believe that they both have some preservatives in them that are known for causing a little bit more irritation. That is, in fact, what my gynecologist told me more than 10 years ago. When I needed estrogen, he said, we're not going to do any brand names. You're too sensitive. We're going straight to a compounded estrogen cream that is preservative free. And I'm very thankful that he did that. So maybe it's just dose, honey. Maybe they're just giving you too much. Maybe you can cut the dose down. You have to talk to your doctor about that. Linda said, I started Elmeron in 1996. You were on it for 19 years. Truthfully, I'm better off of it than I was on it. Is it true that Elmeron is a synthetic polysaccharide, whereas Desert Harvest is a natural polysaccharide? I do have terrible eye damage now. Okay. Cause and effect. Remember that the concept of a coating is that of a Band-Aid. It's a Band-Aid. It's a coating that will wash out of the bladder with urination. I mean, that's the hard part about treating the bladder. Is if you got a bladder disease, most people would say, well, just put the medication in the bladder. But what makes the bladder a very difficult target organ is we pee constantly. Then when we put medication in the bladder, that medication comes out when we pee. It is a great challenge in what we call drug delivery. How do we deliver medications efficiently and effectively to the bladder wall? The problem with a coating, whether it be Elmeron or aloe, is it's just a coating. The bladder is not made of plant material. There is not a single published study showing that aloe is helpful for the bladder and or for IC. At least the last time I looked. Let me look again right now because I don't want to get it wrong. So I'm going to go over to the National Library of Medicine right now. And I'm going to search for aloe interstitial cystitis. Nada, nothing. Goose egg. Okay, and if we do aloe and the bladder, there are 10 papers really talking more about bladder cancer cells. Here's another cancer, pancreatic cancer, nerve growth factor, tilapia fed, supplemented diet. Okay, anyway, there is no research published in any major journal that shows that aloe has a beneficial effect to the bladder of an IC patient. Remember, aloe got popular years ago because it was the only thing we had. I mean, the first supplement we had was Pre-Leaf. The second supplement we had was aloe. And the CEO of aloe is absolutely delightful, wonderful woman. She was a friend of mine. And she sponsored a ton of IC stuff. You couldn't have asked for a nicer, sweeter, kinder woman. Okay, but here's the challenge. Now that we're phenotyping, now that we're stepping away from this concept that IC is an incurable bladder disease or a bladder wall disease and focusing on our core phenotypes, the role of aloe is now very, 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 very small. For a patient with estrogen atrophy, I have published research showing that a chondroitin-based supplement can help. Or for a patient with interstitial cystitis, bladder wall sensitivity, we have research, 252 patients who took it 6 months, of whom I think 56% had success with that treatment, especially patients with more severe IC. That was a paper published in the Canadian Journal of Urology by Dr. Theoharides just when he created Cystoprotect. And we since have many more chondroitin-based products based upon new information we've learned about IC. So the only role for aloe for me now is if you have a bladder wall flare. I mean, soothing the bladder after a flare, short-term use makes total sense. I'm for it. But for long-term use, there's just no research. And so when money is so tight like it is right now, I've said this for decades running the IC network, put your money into something where we have research. Like, for example, Lactoferrin, which Linda's just asking about. So is Lactoferrin a coating just like Elmeron and aloe? Absolutely not. Not even close. So a year and a half ago, researchers in I think it was in Europe, wasn't it? Yeah. It was in Europe. It was at a university in Italy. Did a study with lactoferrin first in recurring UTIs, and then 3 years later they did a lactoferrin IC study. So lactoferrin is a protein found in our immune system. Our body makes lactoferrin. We have lactoferrin right now in our tears. We have lactoferrin right now in our vaginal fluid. Lactoferrin is kind of a front line of defense against infection. Lactoferrin makes it much harder for bacterial, viral, and fungal infections to grow. Okay, so it is a natural, normal part of our immune system. However, in some patients, lactoferrin levels appear to drop. And we don't necessarily know why. Sometimes it's age-related, and other times we don't know. And so researchers began supplementing with lactoferrin derived from cows. Now, lactoferrin comes from milk. It comes from colostrum. This is not made in a lab. The original lactoferrin, you harvest it from colostrum. And they have studied it with a wide variety of adult human diseases with really solid success. And then, of course, they did the recurring UTI infection, where it makes total sense. If we boost and strengthen our own immune system to help our immune system fight off infection, that's a win. And that study showed that it was a win. Now, the IC study was, it was a medium-sized study, and it was a very smart study in the sense that they looked at the bladder before treatment and after treatment, and they measured systemic inflammation through blood testing. Would lactoferrin reduce inflammation throughout the entire body? So patients took lactoferrin for roughly 4 to 6 months, somewhere in there. At the end of that study, and they did cystoscopies before and after treatment. They looked at the bladder, they mapped the bladder, they mapped the redness in the bladder, they mapped the lesions in the bladder. Then they put them on the lactoferrin. And when the lactoferrin was done, they went back and looked. And what lactoferrin did is red inflamed bladders became pink and healthy. Hunner's lesions were almost completely gone. They had trouble finding where they were. And most importantly, systemic inflammation dropped significantly. Now, here's the thing. I mean, this study came out a week after I'd had my breast cancer surgery, and literally, I couldn't sit here. I couldn't sit at a computer comfortably for months. I was sitting in the recliner on pain meds, reading the latest research, going, what? It healed lesions? What? I just couldn't believe what I was reading. And I was really on pain meds back then. So I just put it aside for a couple months. I put it aside for a couple months, and I had to get myself off of pain meds and make sure that I was thinking normally. And so I went and looked at it again 3 months later, and by golly, it did. It did. And right now on the IC Network, if you go over to our main website, icnetwork.org, there's a blog on lactoferrin with all the research, with links to all the research. You can go read that research yourself. Understand that for patients with Hunner's lesions, there are very few options. Very few options. And so to think that we might have something that might reduce lesions for some people with an outstanding side effect profile, I put it out there because I understand the patients are suffering with Hunner's lesions. And the first phone call I got back was for a patient who had only taken it for 3 weeks. And she said, Jill, for the last 10 years, I've gotten up every hour. On 3 weeks of lactoferrin, I'm now sleeping 3 hours at a time. And I just drove in a car for 2 hours, and I didn't have to use the restroom once. She was gobsmacked. She was stunned. And we're seeing that. Not helping everybody, of course, because we're all different, but there are some people that lactoferrin is helping, and it is an over-the-counter supplement. It's right. So I I called the researcher, or I emailed the researchers in Italy, and I said, I'd like to import your product here in the United States for our patients here. We could not come to an agreement because there are a lot of costs associated with importing, especially now. Oh my God. I could not afford to pay those costs. And they had shared that they source their Lactoferrin from Australia. And so I went to Australia and I got Lactoferrin from Australia, and that's what's in the IC Network shop. Not identical to what they did. They added a little bit of alkalinizing agent to theirs. But anyway, it's right on the IC Network website. Patricia says, does Lactoferrin address mainly the Hunner also? No, I don't think so. I think Lactoferrin is for possibly anybody who's got bladder wall inflammation and irritation, whether it's from Hunner's lesion or you've got just a profoundly irritated bladder or even infection in that bladder. Hold on one sec here. Linda said, I was awarded a settlement from the Elmeron lawsuit. The lawyer got a lot of it. Exactly. The lawyers are getting at least 40% plus fees. You know, the highest award that I've had a patient tell me, I had a patient get $1 million. The lowest award of the patients who have talked to me was about $250,000. Kayleen says, happy International Women's Day. Absolutely happy International Women's Day. Ladies, let us stand together, especially when it comes to women's health research, because right now women's health research is struggling tremendously. Yeah, you got to understand that, back in the 60s and 70s, women's research was barely funded. They thought men's research could apply to women. And it's like, hello, we have breasts, we have estrogen, we've got all sorts of other things. And it was a really concentrated effort for women's health advocates to make those changes and to get the government to change. And now we're sliding back again. Very important women, we need to speak out. We need our research into breast cancer. We need our research into any number of conditions which can affect women. And remember, it's not left or right. It's not Republican or Democrat. It's billionaires versus the rest of us. Linda said, Silk Peach estriol cream over the counter works for me way better than estradiol. Thanks for that recommendation. I've never heard of that before. Anna says, have I heard about treating IC with low-dose naltrexone? Yeah, that's a question that's asked in almost every meeting. The study, I think that there was just one study, but here, hold on a sec. This is one that I'm not as familiar with. So we have low-dose naltrexone for chronic pain. It improves post-COVID-19 symptoms, a promising treatment in immune-related diseases and cancer therapy, treatment for chronic fatigue syndrome, off-label. I think that there's only one study with interstitial cystitis. Let me see if I can find that. No, they're not. They're just lumping it all together in chronic pain conditions. So this is a December 2020 study. They were evaluating the efficacy of low-dose naltrexone in the management of chronic pain to determine its potential use for chronic pain in the mouth area. 793 studies were obtained. 8 articles were selected for evaluation, including 4 case reports, 3 studies. Low-dose naltrexone provides an alternative in medical management of chronic pain disorders as a novel anti-inflammatory and immunomodulator. It can offer additional management options. Although they say, owing to the size and heterogeneity of the study, that means diversity of the studies, more large-scale studies are needed, along with additional studies. Anyway, for specific pain conditions. Hold on one sec. Alrighty then. Tanya said, glad to hear last week that my guy knew a pea leaf and Lactoferrin when I took the bottles. Why didn't he recommend these supplements? Heard about them from you. We are now getting a urogynecologist on our medical system soon in Orlando. Well, you got to remember that most doctors have a protocol that they have to follow, a formulary that they have to follow that's developed by either their HMO or their health system, and they're generally expected to follow that system. And many of those systems are very reluctant to suggest supplements. I think number one, because they don't make them any money. But number two, they really like a lot of proof that things work. And so they're going to go for the double-blind placebo-controlled study. And even then, if there's one thing we've learned in the last 30 years is that bladder therapies often don't work for IC patients anyway, even if they're double-blind placebo-controlled. Why? Because the IC patient population is very diverse. We got apples, oranges, and bananas. We got 100 lesions. We got pelvic floor. We got widespread pain, etc. Estrogen atrophy. You can't put all those patients in the same study and expect the study to work for everybody. It doesn't work that way. Linda says, the Lactoferrin really seems to have changed something with me. I use the enteric-coated capsules. I'm basically in some kind of remission, even though I'm almost afraid to say that out loud. 3 weeks was my magic number for the burning to stop. Excellent. I'm so happy, honey. Diane says, I've been taking it since you first started talking about it, about a year. I think 100 milligrams a day, so just a maintenance dose. I've also had 2 steroid injections into my 100th lesions and my bladder, the last one being in mid-December. I also do PT&S treatments once every 4 weeks. I'm so much better. Don't even have to think about my bladder. Oh, that's wonderful, honey. Kayleen said, I had really bad bladder and vulva spasms on Wednesday, so I called the urologist thinking it was something from the Botox. My period has been due for a week and nothing. I did a urinalysis on Friday. All it shows is microscopic blood. Is this normal now 2 weeks after Botox? Kayleen, I would think it's more likely related to the fact that your period is overdue. It's very common to flare the week before your period starts. Victoria said, is anybody else having pelvic floor dysfunction and go to pelvic floor physical therapy? Me. Linda, 87%, or Victoria, 87% of IC patients have tight pelvic floor muscle. Pelvic floor physical therapy is now standard of care. Linda said, I bought the Lactoferrin the first day I heard of it. I can't thank you enough. You're very welcome, Linda. I'm really glad it helps. Lavelle says, after years of Elmeron, I cured my IC with Ivermectin. Well, Lavelle, I'm glad you're doing so much better. We just have no data. You should ask your doctor to publish your case as a case study, because I am not aware. Let me look at it. Let me look. Maybe I missed it. I'm going back to the library, National Library of Medicine. I'm going to search for Ivermectin interstitial cystitis. Nothing. Not a single study which has found that Ivermectin could help IC. I mean, I believe you. I believe that it helped you. I couldn't offer an idea as to why it would help. We have phenotypes now. So the ivermectins are common antiparasitic drugs. Yeah, we used to give it to our horse, right? This was very controversial during COVID because there were people saying you should take it for COVID and what's the evidence. Listen, I haven't done enough research to be able to comment on that at all. All I can tell you is there's not any published research showing that it's helpful for IC. Let's see if it's helpful for the urinary tract. Oh, well, this is a fascinating discussion of parasites in the bladder. Urinary myiasis, not your typical urinary tract infection. Here's lower urinary tract symptoms caused by scabies, mites. Malacoplakia, whatever the hell that is. Here's a case of Piersonemia eggs in the urine sediment of a cat in Trinidad that was treated with ivermectin. Here's one, diagnosis and therapy of the Capillaria plica infection in dogs that causes cystitis with hematuria. What is Capillaria plica? What is that? Here, hold on. Capillaria plica. It's a worm. It's a parasitic nematode. Oh, look at that. Often found in the urinary bladder and occasionally in the kidneys of dogs and foxes. It's also been found in the domestic cat and various wild animals. Its presence usually produces no clinical symptoms, but in some cases, it can cause blood in the urine, cystitis, or difficulty urinating. Wow. It's been found in badgers, minks, brown bears, coyotes, a fisher, a lynx, a marten, a shrew, a raccoon dog, red fox, skunk, and wolf. Yikes. Now, I can think of one patient that I believe had a parasite in her bladder and completely symptom free, went and spent a couple months in Costa Rica. They were doing research in the waterways, and she was actively swimming and collecting samples in muddy brown water. And while she was down there, she started developing bladder symptoms. And by the time she got back to the United States, her bladder symptoms were really, really intense. And if you were to talk to me, one of the questions I always ask is there any event that you associate with the onset of your symptoms? And in her case, she said, yeah, I went to Costa Rica. It's like, okay, what'd you do in Costa Rica? She said, well, I'm a researcher. I was in the waterways. Like, oh. Have you ever considered the concept of a parasite? And I sent her off to an infectious disease specialist. Kayleen said, I wonder if my testosterone levels are going up again. I stopped the spironolactone last month when I was in the hospital. Maybe. Linda said, it's interesting that I had taken ivermectin for a flu right when I started the Lactoferrin. Interesting. Now, I'm sure I missed some questions here. Okay, so on Facebook again, guys, if I missed your question, just ask it again. All right. So for anybody who joined the meeting more recently, we now have some early research that has found that Elmeron bladder installations or Pentosan bladder installations has led to retinal damage in at least one patient in a study. And more importantly, the injections of Pentosan Elmeron for arthritis, 3 patients who had it injected in their body developed retinal damage, which is really stunning to me. I'm really stunned by this. Joanne said, I'm in the UK. Can I get Lactoferrin here? Do you post to the UK? Problem could be at customs and possibly high customs charges. Does anyone in the United Kingdom supply Lactoferrin? I think you can find Lactoferrin in the UK. I'm sure you can. I mean, if you can go to a health food store, ask them there. You know, Brexit was a disaster for imports, so we can't send to you. But you might even be able to get the lactoferrin that was used in the IC study from Italy. It was called Valpalf, Valpalf. So I don't think you'll have any problems finding lactoferrin there. You just have to look for it. The other thing you could do is make friends with somebody here in the chat, somebody based in the United States, and they can buy it for you and send it to you as a gift. You can reimburse them, or you can buy it, use them as a shipping address, and then they can send it to you. I cannot send it to you. The way it works is that with Brexit, is that we have to file with your government for approval to export our products to the United Kingdom. And we have to pay full-time a consultant to do that. And that's like $50,000 a year. We can't afford that. Can't do it. So the best thing I can say to you is make friends with somebody in the United States and let us send it to them, and then they can send it to you as a gift. But when we send it, we have to put a customs form and all that sort of stuff. And they're going to look at the customs form and they're just going to block it and send it right back to us. And you're going to be out that money. Tanya's going to dinner. Not a problem, Tanya. See you later. Valerie said, any suggestions for IC patients who also have IBS constipation? Yeah, totally. Because I'm one of those patients. I used to have really bad IBS constipation. I mean, I rotated. I would rotate in my 20s between extreme diarrhea and then extreme constipation. So if you have IC or IBS or vulvodynia or TMJ or fibromyalgia or migraines, that puts you into the widespread pain phenotype. So these are roughly 40% of IC patients have other pain conditions. And research has now linked that to the central nervous system, that it is an injured central nervous system that is playing a role in all of these extra pain conditions. We call it nervous system dysregulation. And so, number one, we have to make sure, sorry guys, oh God, my incisions are just so uncomfortable today. If you see me going, it's because I moved the wrong way. Gosh darn it. So it just zapped me. Just bear with me here. It'll calm down. Ugh. You know, you like to think after you have surgery that everything gets better. And it's like, no, sometimes you can have nerve damage. And I have nerve damage. Okay, calm down. Just calm down. I did a workout at the gym last week that just aggravated everything. Okay, so concept number one here is, what can we do to calm your nervous system down? Generally, patients who have widespread pain also have anxiety disorder. I had terrible anxiety disorder in my 20s when this really, all the related conditions hit me at one time. What research shows is that And we have a fabulous research team called the Chronic Pain Research Alliance. And they were brought together to try to solve the mystery of why do some patients go on to develop all these pain conditions. Right. Okay. So here, and Victoria has vulvodynia. So we'll talk about that too. So the Chronic Pain Research Alliance started studying our nervous system, because what's a connection between all these different parts of our body? It's our nervous system. And they made an absolutely remarkable discovery. And this might sound a little scary, but it's not. There's a real happy ending here. When they started studying the brain, they found that the brain of patients with widespread pain was not behaving normally. That our brain was stuck in a constant state of fight or flight. That 24 hours a day, 7 days a week, our brain was behaving as if a saber-toothed tiger was going to eat us. And here's the problem. Fight or flight is meant to be short term. I mean, like literally, if you open your door and you see a fire, your sympathetic nervous system, the fight or flight center, takes charge. Fight or flight is controlled by your brainstem, the most primitive part of your body. Your brainstem has one job: to save your life. And so all your brainstem does is monitor your sensory input. What do you see? What do you hear? What do you smell? What do you taste? And what do you touch? It's constantly scanning for threats. The minute it senses a threat, it takes over the brain. The sympathetic nervous system stops the parasympathetic nervous system. It wrests control of the brain. It turns on a structure called the amygdala, which is the command and control center for fight or flight. Now, when you're in fight or flight, what does it do? It raises your heart rate, it raises your blood pressure, it tightens your muscles to prepare you to fight, flee, or freeze. But generally, fight or flight is short. Again, if you open your front door and you see a fire, of course you're going to go into fight or flight. But hello, it's 2026. You call the fire department. They come out. They put the fire out. An hour later, 2 hours later, the threat is gone. And when the threat is gone, fight or flight is supposed to turn itself off. The parasympathetic nervous system regains control of the brain, and it calms everything down. It lowers your heart rate, it lowers your blood pressure, it relaxes your muscles. So normally, our brain is supposed to be run by the calm nervous system, the parasympathetic nervous system. But for those of us with widespread pain, we're the exact opposite. The stress command control center is controlling everything. And here's the problem. When you're in a constant state of fight or flight, your entire central nervous system becomes very, very sensitive. And if you're anxious all the time, that acts as an amplifier. That just increases pain throughout the body, because your brain's going, her life is at stake, her life is at stake. And the brain intensifies all the sensations to try to get the midbrain intensifies all the pain to get the upper part of the brain to take action. I hope that makes sense. I'm trying to say that the right way. The problem is, again, if you're stuck in fight or flight, everything intensifies. The nerves become more sensitive, the pain becomes more intense. And then you start catastrophizing, and then you have a lot of anxiety and all this other stuff going on. Now, why does this happen? Well, what the research shows is that for 80% of the kids who go on to develop widespread pain, there is a major physical injury. A major physical injury. So I was working with a patient who had a very bad broken back. Another guy, a man who had terrible IC symptoms, who was hit by a car and had a crushed hip. Okay, it takes 14 days of intense pain to put the brain into a constant state of fight or flight. So again, for 80% of the kids who develop this have a major physical injury. For the other 20%, it's a history of a bullying or abuse. And the common theme in my office when I work with patients is growing up in the home of an alcoholic, especially a violent alcoholic. It's all about your perceived sense of safety. So one of my clients, for example, shared that her father was very violent. And so as soon as they heard the car of him driving home from work, they went into fight or flight. As soon as he started drinking, they became even more hypervigilant. And when he drank to a certain point, he started to get violent. She would go lock her and her brother in the bathroom, and then he would tear the door down and beat them miserably. This went on her entire childhood. So her brain lived in a constant state of fight or flight until she got out of there. The problem is her brain basically, that was her normal. She had a legit threat to her life. She had a violent, abusive father. Now, in my case, I grew up in a neighborhood with a kid who became a rapist and murderer, and I was attacked in 4th grade. I was one of his favorite targets. I ran home. I ran to school as fast as I could, ran home as fast as I could. My identity will forever be a little redheaded girl running for her life, because that's the way I felt. And, so that happened in 4th grade. I was attacked in 5th grade and 6th grade. Then in 7th grade, I fell and broke my tailbone. And all of a sudden I had frequency urgency. So the muscle injury played a role, but that didn't explain why I then had vulvodynia in high school. Then I had terrible IBS in my early 20s. Then I got migraines. Then I had all these crazy sensitivities. And then I had bladder pain for the first time when I was 32. That's all central nervous system driven. How do we know the central nervous system is involved? Patients with this often have very sensitive skin and a wicked sense of smell. We can smell things that other people can't smell. That is a classic sign of a hypersensitive central nervous system. So, concept number 1 is, if we're dealing with widespread pain like that, it's very important that we get you out of fight or flight. And just taking a really good class in anxiety management like I did completely changed my life, or doing some EMDR therapy is very, very important. We just have to recognize that there's more than just a bowel or a bladder issue going on. There's a nervous system issue going on. And then the second thing that we have to really think about is the health of the bladder in general. Here's the challenge. For many IC patients, especially when we were newly diagnosed, we were all given massive amounts of antibiotics. I dare you to find a patient who was not given antibiotics when their symptoms first began. And antibiotics destroy the biome. And so we have to look at the health of the biome. We want to make sure the biome is healthy. And we also have to understand that the nerves in the bowel are very, very vulnerable. They're easy to turn on. There's a great website, helpforibs.com, that talks about making sure that you're not eating foods that will trigger the nerves down there. And most importantly, getting that fiber intake up. We've got to have your fiber at 20 to 25 grams of fiber a day, not insoluble fiber, not Metamucil, not psyllium. That's too aggressive for the sensitive nerves in our IBS. We need acacia fiber, or basically eating a really good serving of green peas a day or every other day. That's my go-to, green peas and navy beans. Got to get that fiber up. If you want to talk about it, feel free to give me a phone call. I can share with you a lot of the things that I did. My IBS has been controlled for quite some time now. So hold on a second. Cookie says, what can I take instead of Elmeron for my IC? Elmeron is very expensive and I'm scared to take it anymore. I can't afford it. Yeah, Bladder Builder is a supplement, or Bladder Rest. I have an Elmeron transition guide over on the IC Network website. Because again, patients have been transitioning off of Elmeron for years. Let me get a link of the link of it for you, hon. I think this will help you. Here. So I'm going to give you that link here in Facebook. also give you that link here on YouTube. Jessica said, are there any studies? And the answer about the low dose, and the answer again is no. There are no studies showing it's helpful for IC. There are studies showing that can be helpful for chronic pain. Okay, Victoria said, I also have vulvodynia. Any tips or trips for flare-ups? Okay, now vulvodynia can be caused by a number of different things. So vulvodynia means pain on the vulva. Vulvo means vulva, dynia means pain. And it's kind of unspecified. A diagnosis of vulvodynia basically means, yeah, you've got pain on your vulva. It doesn't necessarily explain why you have pain on your vulva. So really, one of the first things we're going to look at is the quality and health of your skin. So your vulva is a mucous membrane structure. It is wet. It is meant to be wet. It's like your mouth. Your vulva, your vagina, your urethra, your bladder, and our mouths are all covered with mucus. And that mucus plays a really important role in the health of that skin. It protects that skin. So concept number one here is there any chance that you're starting to get dry from estrogen atrophy? So if, for example, you're on a strong birth control, if you're on Lupron to prevent endometriosis, or you're on an estrogen suppression agent for cancer, or you're just getting older. Dry mouth hurts, dry vulva hurts. So that would be concept number one. The second thing we're going to look at, is there any chemicals that could be irritating the skin down there? A good example is many of the wipes that are sold are actually irritating. Whether it's a diaper wipe or whether it's Cottonelle, anything like that, some patients can react to wipes. And so that would be concept number one. The second thing we're going to look at are things like fabric softener, anything that's leaving a chemical in your underwear. That chemical is now perfusing, I don't know if that's exactly the right word, but it's going up onto the skin of the vulva, into the vulva where it's causing irritation. So it's very common for fabric softener to be a problem. I once had a wicked flare from a fabric softener. Also, man, because I am a vulvodynia patient, if I put on any underwear washed in the old Cheer detergent or Tide, within 5 minutes, I will have discomfort. And you know, the funny thing is, see, like when I do my underwear, I use 7th generation free and clear. I do an extra rinse cycle as part of that wash. And then I do another rinse cycle. I do 2 rinses of all my underwear. I don't want any chemicals in my underwear at all. And it's really funny how sometimes if you forget to do that, I know you've washed all your underwear and you put them in the, and you know, they're ready to be used. You put them in your dresser and then you put it on and it's irritating. Like within the first 5 minutes, you're going, okay, why is my skin so prickly down there? And then you go, oh no, I forgot to wash them. I forgot to rinse them again. Then you have to go get all your underwear and rinse them off again. So look at chemical irritation. Then the other thing we really want to look at, especially if you've got perineal pain, is tight muscles. There are muscles immediately above your vulva, your levator ani muscles. And if those muscles are tight, they're squeezing nerves and they're squeezing blood vessels. If you ever have pins and needles on your vulva, that's a tight muscle squeezing a nerve. And so we want to make sure you don't have tight muscles and or pudendal neuralgia. And so having a pelvic floor assessment is important. We know that we have research that shows that physical therapy has actually helped many vulvodynia patients. So our job here is to try to identify why you have vulvodynia in the first place. Like, why do you have IC symptoms in the first place? What is the underlying cause? One of the products that I love for anybody with vulvodynia, well, I have 2 suggestions. Number one, a peri bottle. So, you know, when I was like 24 and I felt like I had a yeast infection all the time, I couldn't wear jeans. Driving was miserable. I found this support group about 10 miles south of my town. And I drove down there on a Saturday, and it was filled with, you know, I mean, I was like 25 and they were all like in their 50s and 60s. And they took me under their wing and they said, Jill, the first thing you do is you use a Perry bottle. So a Perry bottle, here, I think I have one. So every member of the IC network gets a free Perry bottle. So this is a plastic bottle that you fill with water and you leave it next to your toilet. And every single time you pee or have a bowel movement, you rinse yourself off. Because here's the thing. Urine is irritating. Urine is body waste. It's toxic. It's stimulatory. And toilet paper will not get all the chemical the residual chemicals from urine off of your skin. Water will. And they told me the most important thing you can do with vulvodynia is just start using a bottle. Oh my God, they were so right. They were so right. The thing that helped me the most with my wicked vulvodynia was this. It calmed everything down. In fact, every bathroom, every woman in my family uses these. Again, every member of the IC network gets one of these. There's in every bathroom. Rinse yourself off. And you can, if your urine feels hot, like it's burning you, you can fill it up with cold water and squirt it on you while you're peeing. Then the second thing that I personally love is vulva balm. So vulva balm is mimics normal mucus. It's a kind of a protective coating that's made with organic olive oil, avocado oil, and sea buckthorn oil. Here it is right here. That's what it looks like. We open it up. That's what it looks like. It's as close to normal mucus as you're going to find, and it's very light and it's not messy. And you can use this every single day on your skin, and it's wonderful. So if you're ever feeling dry or urine's really irritating you, put some of this on before you pee, and you can use it a couple of times a day. It's not a medicine. It's just protective. All right. Okay, here, hold on a sec. Natalie says, I tripped on cement stairs and my lower abdomen landed on a step. Since then, I've had horrific clitoral pressure along with an intense need to urinate, but the urine stream is very weak. My bladder is also sore. Not seeing my physical therapist for 2 more weeks. How can I relieve the pressure and urge to urinate? Well, honey, you know, girl, man, you had a massive injury. You had, I mean, clearly when you hit your belly, you compress muscles and nerves. The fact that you're having clitoral pain afterwards means that pudendal nerve got tweaked. So, hopefully you've been to like urgent care. Have you gone to urgent care yet? If not, go to urgent care. They need to look at your bruising. You know, explain to them what happened. And if you have tight muscles, they can prescribe a muscle relaxant like baclofen or Flexeril. That might be very helpful in reducing some any tight muscles that are squeezing nerves. But you also might have to do something that will calm that nerve down. Don't sit on this. Don't sit on this for 2 weeks. Go to urgent care if you can and just let them study your body. Maybe you need to get, you know, a CAT scan or something like that to try to understand what happened down there. Maybe you broke your tailbone. Oh, except you landed on your front, but I'm concerned. So I don't know how to relieve the pressure or the urge to urinate. I mean, I think you're going to have to just go back to, you know, IC 101. No coffee. Don't do anything that's going to provoke your bladder at all. No caffeine, no green tea, no black tea, no cranberry, no orange, no citrus, nothing. Nothing that's going to provoke your bladder. And then if you got your appointment with your pelvic floor, call them every day, see if they have a cancellation so you can get in quickly. But I would be very tempted to go to urgent care and just let them look at your body to see if they see anything funky that might have happened with that fall. Because having clitoral pressure after falling on your belly, that's concerning to me. I don't understand what would have happened. Yeah, I mean, the pudendal nerve comes off your spinal cord, you land on your lower belly. Did something push up into the nerve? That's complex. I'm really sorry that happened to you. And I urge you to talk with a doctor, just to have some basic scans just to see if anything funky. Lori says, how does ivermectin cure a bladder lining? It doesn't. There's no research showing that ivermectin is a treatment for IC. One person shared that she had success with it. That's great. I totally believe her. But ivermectin is an anti-parasite. And so I guess it might help if you got a parasite burrowed into your bladder wall, which would be rare, but in the United States, that would be very rare, but that's actually quite common in other parts of the world. But it's not, the challenge is why is your bladder lining compromised? Ivermectin is not going to fix estrogen atrophy from aging. Don't even go there. Estrogen atrophy from aging and from estrogen atrophy is just aging. It's not a disease. You're just aging, and you don't cure it. You give the body what it needs to make more estrogen, to make more bladder lining and mucus, which is estrogen. Victoria said, I was in fight or flight for the last 2 years, and I can say I'm finally out of it. Excellent. Hello, Paula. Nice to see you. Lori said, I used Desert Harvest Aloe and some bladder builder. Okay. Hello, Johanna. How are you doing today, hun? Brandon said, is there any relationship between having chronic fatigue syndrome and IC? Yes, there is. That's part of the central nervous system dysregulation. Absolutely. That's part of that widespread pain phenotype. I mean, this is, let's see, how do I want to say this? Years ago, like 15 years ago, Ken Peters, who runs really probably one of our best research teams in the world. He's at Corewell Health. He's the chairman of the urology department, big IC researcher, master diagnostician. One of the things I really like about him is that he's not invested in one specific treatment. He has a very broad view, and he doesn't try to make the treatment fit the patient. Like, he's not the Elmeron guy. Like, he looks at the patient, understands their body, and then prescribes a treatment based upon what he finds. So if he finds tight muscles, you're going to get treatment for tight muscles. If he finds this, you're going to get treatment for this. Anyway, he did a lot of early kind of studies that other researchers wouldn't have done. And one of the things that he was looking at was childhood trauma. I think the incidence of abuse and trauma. Yeah, that was definitely a study that he did. So, and of course, when I was first diagnosed back in 1993, I distinctly remember UC Berkeley, University of California, Berkeley, was doing a study on why do some IC patients have a very wicked sense of smell. I remember that. I totally remember that happening here in Northern California. And I think they abandoned the study, but that was, so we started having kind of trickles of this and trickles of that started pointing to trauma and nervous system. And the other really important thing is, why have so many bladder treatments failed in research studies? You know, I mean, the harsh reality is that pretty much every bladder treatment ever studied in a wide scale study is barely better than placebo, and most have failed. And it's very hard for a pharmaceutical company to want to invest in the IC market when pretty much every study failed. And so there's been a lot of discussion in the last 7-8 years about, well, why have all these studies failed? And they listened to us, they listened to the patients, and they also saw that there were many different types of patients. And slowly light bulbs turned on. It's like, oh, well, maybe there's just different types of patients. You know, maybe this patient's going to respond to this therapy, this patient's going to respond to this therapy. And that was the advent of phenotyping. And it was the first protocol was published by Dan Shosky and Curtis Nickel, called the U-Point system. And they said, okay, when you're working with a newly diagnosed patient, we want you to look at their symptoms. We want you to look at their muscles. We want you to look at their nervous system. We want you to look at the health of the bladder wall, and we want you to see if there's any infection. And doctors were supposed to evaluate all those, and then based upon what they found, treat what they find. And then Chris Payne came out with his 5-point system, which is what I use. I love his system. He believes that there are at least 5 different types of patients. And he thinks that there are more that will soon to be discovered. And so his were Hunner's lesions, bladder wall driven without Hunner's lesions, pelvic floor driven, pudendal neuralgia, and widespread pain. And now that we have more research that has been exploring and phenotyping, they have now really firmly established that there is a widespread pain group characterized by this very central sensitive nervous system. And we know that patients with widespread pain don't respond to bladder treatments, they respond to systemic therapy. Whereas patients with bladder wall symptoms respond to bladder treatments, but they don't respond well to systemic. So anyway, that's all research that's come in that's helped coalesce these different groups. And now we pretty much think it's a widespread pain group that has sabotaged every IC study. you know, every bladder treatment where you included widespread pain patients, you're just tanking the study. And I got into a big argument. We did a National Institutes of Health meeting about, I think it was before COVID, right before COVID, where we were talking about the future of IC research. And I just said, listen, the only way we're going to get new research is if we give companies an on-ramp to success. And the way we do that is they have to phenotype before the study. So we're only going to test bladder therapies on bladder patients, and we're only going to test nerve therapies on nerve patients. We're not going to mix it all up and mess with the results. And this other doctor was like, no, the researcher needs to include everybody in phenotype afterwards. And I said, why? We've done that for 20 years. It hasn't worked. You can't put apples, oranges, and bananas in the same study and expect success. Let's break them out. Put the apples in the apple study, put the bananas in the banana study. And he was, like, listen, I'm not, I don't run a big research program. He ran a big research program. I'm just a IT support group leader who has a lot of scientific training. And, I just went for it. It's like, no, don't do that. What a waste of time. And anyway, now, 4 years later, they're now saying, yeah, you got a phenotype before the study. Okay. So I guess what I'm trying to say here is that there is a very clear link between chronic fatigue and IC and fibro and migraines and IBS and vulvodynia and having very sensitive skin and a wicked sense of smell. It's nervous system dysregulation. And now that we know that, we have to focus and work on your nervous system. And that's where PEA would be very interesting to try, either Peora or P-Leaf. And by the way, there's going to be a really big sale on P-Leaf shortly, 30% off, right? Okay, so this is palmitoyl ethanolamide that acts to calm nerves down. So people ask me, what do I take? This is what I take, because I know for me, my phenotype is nervous system driven and pelvic floor driven. I'm not going to waste any money doing bladder treatments. My bladder is fine. It's fine. It's always looked fine. In contrast, my muscles are screwed up. And my nervous system, I was traumatized as a kid. Susan said, is there any relationship between Hashimoto's and IC? Not that has been verified in a study. And let me just look real quick. Let me just see if anything new has come out. So back in the day, before social media and hundreds of thousands of patients used our website and talked about IC, we definitely tracked a lot of thyroid dysfunction. There's no doubt about that. We did, and we never understood it. Some patients were hypothyroid, some patients were hyperthyroid. Quite a few patients had Hashimoto's. I don't have, it's an immune disorder. So is there a phenotype that is an immune-driven phenotype? I think there is. I think that patients who have lupus, Sjogren's, and maybe you could put the Hashimoto's in, that could be a distinct phenotype in the IC patient population because it's being driven by an immune. And listen, there are some people out there, there's some doctors out there who are saying everybody with IC has an immune problem. That's not true, because so many patients develop IC after falls and hurting their pelvis. There's real injury is a real big common cause of urinary symptoms. If I were to guess, the research has shown that 3% of the overall IC patient population has other immune diseases like lupus, Sjogren's. So I would put Hashimoto's in that group. I think, but do we have enough research to validate my theory? The answer is no. So you're not going to see anybody breaking that out into a group yet. But I think it'll happen eventually. I do. All right, you guys have gotten real quiet on YouTube. What is up? Susan, okay. Johanna said, I found out that medicines in my installations, heparin, lidocaine, sodium bicarb, and Kenalog. Okay. So Johanna, just so you know, we now have our first reported case of a patient who is doing Elmeron bladder installations who developed retinal disease. So I'm glad that you're instilled. What you're doing is a classic rescue installation. So that's the most common bladder installation. It's called a rescue because it can rescue you out of a flare. Right? So if you're in a wicked bladder flare and your bladder's screaming at you, you can call your doctor and ask for a rescue. And the heparin coats the bladder, and the lidocaine numbs the nerves in the bladder. The sodium bicarb alkalinizes it so it absorbs a little bit more. And the steroid Kenalog just kind of calms things down. So that is kind of the perfect formula for a rescue install, and that's the most common bladder installation out there. Tabitha said, is magnesium glycinate good for calming nerves? I don't know. Let me look. I mean, I take magnesium glycinate for muscles. Let's see. Has a calming effect, reduces anxiety, and eases muscle cramps. They say it helps to regulate the nervous system. Okay, how does it do that? It has the glycine component helps create a calming inhibitory neurotransmitter effect in the brain, which can aid in easing anxiety. Maybe. I mean, I take magnesium glycinate at night. If I don't, I get really bad cramps in my calves. Victoria said, my muscles and nervous system are messed up as well, which I believe caused my IC. Yeah. It's kind of the chicken versus the egg dilemma, Victoria. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor or the nerves. You know, nothing operates in isolation in the pelvis. Everything influences everything. And where Western medicine fails is that doctors play in their sandbox. They just play in their sandbox. So urologists focus on the urinary tract, gynecologists focus on the reproductive tract, and they don't necessarily look at other things which can influence both, like tight muscles and irritated nerves. And blood vessel issues. Sometimes there are blood vessel issues going on. So there you go. Cindy said, I saw you on an ad on Facebook for P-Leaf, not Pre-Leaf. Is that real? You better believe that's real. Here it is right here. Absolutely. That came out a little less than a year ago. And so we have 2 palmitoyl ethanolamide products. We've got Peora and P-Leaf. And, you know, a lot of people say, well, what's the future of IC? And again, the future of IC is phenotyping. I mean, that's it. Absolutely phenotyping. Everybody agrees with that. So when we talk about, I hate to say it, but a next generation treatment, we're letting a lot of the legacy stuff go because we know it doesn't work. Instead, we're doing customized treatment plans based upon your unique case. And really what's changed everything is PEA, because that acts to calm nerves down. Now we're all trying to calm nerves down. And there are dozens of studies with the active ingredient in this, palmitoyl ethanolamide, for acute pain, chronic pain, surgical pain, burning mouth syndrome, migraine, shingles, you name it, they've done it. Outstanding safety profile, and it acts by calming nerves down. So this, I believe, is really the future of supplementation. And we have new research that shows that it can be effective for menstrual cramps and lots of other different types of pain, and that it can help literally in the first couple of hours, that in some conditions, the pain level can drop by 30%, which would mean that you wouldn't necessarily have to go to a stronger pain med if we can bring some of that pain level down. Not an opiate, no risk of no risk of addiction, anything at all like that. And better yet, it's really affordable. You know, it's like under $40 for a supplement. That's great. Tabitha said, is the powdered PEA just as effective as in pill form? I have powdered PEA right there. Now, I don't have this in the IC Network store. You can buy powdered PEA. There it is. And the reason why I got this is I was adding it to lotion and rubbing it on my incisions to calm my nerves down because I've got neuropathy. across my chest from my mastectomy. But the powder form, whether it's this or whether it's lactoferrin, it's gonna get destroyed in stomach acid. It's always better to have it in an enteric capsule coating that will carry it across the stomach acid where it can be absorbed and be most effective in the bowel. So I wonder, here, hold on a sec. Whoops. Let me just grab a little bit here. I'm going to show you what I'm doing. So I've got a little bit of vulva balm, and I've got a little bit of PEA. I'm going to try to rub it together. And there's research behind this, guys. I'm not freaking out here. Topical PEA has been studied. Yeah, you see, look at it absorbed really well. Here. Hold on a sec. I'm going to go to my incision and we'll see. I'll just try a little bit of it. We just see what happens. Oh, but it's okay. Hold on. Oh, here we go. I have greasy palm. Man, we get creative when we're in pain, right? Oh, and sometimes it's the little things. I know that vulva balm is perfectly safe, and I know that the safety profile for PEA is outstanding. I use it every day, so I'm not worried about it at all. All right, let's see. We have been going now for 2 hours. I feel like I want to drive out to the coast. So how are you guys doing from a weather standpoint? So I'm in Northern California. I'm not in Southern California. I'm about 80 miles north of San Francisco. And we have had a very cold, rainy 9 months. Last summer, Mark Twain has a quote, "The coldest winter I ever spent was a summer in San Francisco." Let me tell you, our summer, we were robbed of last summer and fall. We had hardly any warm weather, and then winter hit, and oh my gosh, so rainy, so cold. I've been so cold, and finally, spring has hit. And it was 80 degrees yesterday, and it was glorious. Oh, I've been walking around for 2 weeks, walking out in the sun. Oh, it's been so good for my mental health to have sunshine again. And I've already walked around. I went this morning and I walked around the lake early anyway, just to get my sunshine. So I hope that everybody starts to warm up sooner rather than later, because I am sick of winter. I want some glorious sunshine. It's 58 degrees in Columbus. It is, I think, 82 outside right now. Donna says, do I ship supplements to Canada? You betcha. We ship to Canada every single day. In Canada, your shipping is a little bit more expensive, of course. Unfortunately, we have customs. So when you go into our shop and you check out and you say you're from Canada and you give your address and your province, it will give you real-time shipping rates. Generally, priority mail is better because it's insured and trackable, but it's a little bit more on the expensive side, but it's not the worst expensive. It's not express. We can ship first class international, but you just have to understand we will not be able to tell you where it is. And up in Canada, there are periods of time where your mail service just kind of stops. I mean, you've had a lot of strikes. Obviously, you know that. But customs up in Canada has periods sometimes where it goes really, really slow. And so sometimes products shipped are stuck in Canadian customs for 2 weeks. And then they try to deliver it and you're not there. And they only try to deliver it once. And if you're not there to do it, they send it back to us right away. So a lot of our Canadian customers have post office, especially if you're close to the border. Like if you're within 50 miles of the U.S. border, even 100 miles of the U.S. border, it is totally worth coming down and getting a P.O. box here. That way we get to ship it to you the cheapest we can ship it to you. And then what our Canadian customers do is they just go down to their P.O. box, or they get a box at UPS store once a week, and they just grab their packages that way and bring them right over the border. You know, so Robbie says, curious if pea leaf could be combined with DMSO as carrier agent. I have no idea. I am not, Robbie, I'm not a fan of DMSO at all. The science behind DMSO is so unclear. It has so many different methods of action that I find it scary. If you ask somebody, what does DMSO do to the bladder wall? You're going to get so many different answers from so many different people. DMSO was created back in the 1950s as a carrier agent to move kidneys from one hospital to another for a kidney transplant. It is a byproduct of the paper industry. And I interviewed Alfred Lobus. I think, no, it wasn't Alfred Lobus. Who was it? It was a guy. No, was it Alfred Lobus? Up in Oregon. No, it might have been. Okay, I don't remember that. I mean, it was like 20 years ago. Anyway, they thought that DMSO would just be a wonder drug for many, many conditions back in the late 50s, early 60s. And so they studied it with a lot of conditions. And you know what? It failed everything but the IC study. And the IC study was like barely successful. And if it were done today, I was told it would never have met today's standards for approval. So its only approved use is as a bladder installation for IC. That said, we don't really know what it does other than it's a penetrant. There's one school of thought that says that it causes all the mast cells to release histamine at one time, so it basically empties the mast cells. And so you're not feeling mast cell irritation for a period of time until they all recharge, for lack of a better term. What I do know is that we have research from 2 research studies presented at the American Urology Association. I was at both meetings by a researcher named C. Suba Packer. And C. Suba Packer was studying DMSO on strips of rabbit bladder. And what she found is that the FDA approved dose of 50% DMSO caused irreversible bladder spasm, that the muscles spasmed and never came out of spasm. And she did a dose ranging study. So at 50%, irreversible muscle damage. And then she went down to 40%, and then 30%, 20%. The dosage that was found to be the safest was roughly 20 to 25%. And I was at that meeting. It was in Los Angeles at the American Urology Association. It was a poster. I went to every single IC researcher that was there and said, what do you think of the DMSO study? Only one study still used it, that it still had a place. All the other ones had stopped using it. And what was even more interesting was when the public discussion period began as a group, Ray Rackley of the Cleveland Clinic, a very well-known urologist, stood up and said, we don't use DMSO anymore. We believe that DMSO is why we've had to remove so many bladders, because it causes such damage to the bladder. And it was like a whoa moment, I mean, like the entire audience was like, wow, did he really say that? Man, he was firm. He's like, we will not use DMSO in our urology clinic at all. And based upon C. Suba Packer's research, they had a discussion and they all agreed that they would not use the FDA approved dose of 50%, that they would always do it in a DMSO cocktail with other ingredients to bring the dose down to 20 to 25%. And that was an informal discussion at this AUA meeting with the top IC researchers in the room. What's disappointing is that they seem to have forgotten that. And if you look at our guidelines are still saying the 50% dose despite her research. So Lori said DMSO for scleroderma injected smelled like fish. I believe it never really helped. Yeah. And generally it smells like garlic. Johanna says, do I know of any carbonated beverage that I could drink that doesn't bother my bladder? Thank you. Yeah, LaCroix. Do a LaCroix. Do a LaCroix berry flavor. Coconut. You know, the only acid in a sparkling water is a little bit of carbonic acid. So from the carbonation. So what you could just do is just open it up, let it gas off for an hour or two, serve it on ice. I'd be amazed if that bothered your bladder. The other thing you could do is you could make an Italian soda. So again, get a carbonated water, open it up, let it gas off for about an hour, just let some of the bubbles go away, pour it on ice, and use a little bit of Italian flavoring. You can buy Italian soda flavoring on Amazon. Tirani is a company. Make sure you do not buy the artificial sugar ones. You got to buy the sugar one. And the best one is probably coconut. But they have coconut, they have peach, they have raspberry. Raspberry is a really good one. You can also buy, but Tirani is a lot more chemical. You know, I think they've got colorings in it and things like that. I know you can buy organic raspberry syrup that you can use to make your own Italian sodas. And just remember, an Italian soda, listen, a regular soda like a Coke is dark brown. Okay, Italian sodas are not dark. Italian sodas are a blush of color. So you're going to use like a quarter cup of soda flavoring in one of these, right? And so this should end up being a pale, clear pink. If it's dark, you're using a lot. And feel free to play with combinations also. But the LaCroix, I mean, I would drink more sparkling water, but I'm very prone to having gas in my stomach. And when I have gas in my stomach, my heart gets all funky. So I'm not a huge sparkling water fan, but when I'm craving it, I go for a LaCroix. San Pellegrino has a great sparkling water that's very popular, but it's also very, very bubbly. And I don't like having a lot of gas sitting in my stomach. Donna says her bladder installations are done with Cystostat. Yeah, Cystostat is hyaluronic acid or sodium hyaluronate. So Cystostat was made by a company called BioNiche. They were located up in Canada. I think it's since been bought by a company in Ireland. Hyaluronic acid is a building block of the bladder wall. It is a molecule found in the bladder, just like chondroitin. So in Canada, there are two different bladder installations. There was Cystostat, which was hyaluronic acid, and then there was Uracyst, which was liquid chondroitin. And these two companies, it was so funny, for about 10 years, man, they were trying to outperform each other, you know, and they were doing all these clinical trials trying to prove that their product was better and then their product was better. And they're both valid. I mean, they're way more valid than aloe because they're actually molecules found in the bladder wall. But then somebody had the brilliant idea of combining them. And when they combined them, they were twice as effective. And that's called Ialuril, Ialuril. And so most of the doctors up there, at least in Europe, I will say, are not using the individual ingredients. They're just going straight for the Ialuril because the research results are so much better. So Donna, you could ask your doctor about that. It's Ialuril, Ialuril. Victoria said, I got bladder installations once a week for about 10 weeks. It worked until it didn't. Interesting. I don't know, what can we say about that? I mean, I did bladder instills and they never did a thing for me, ever. They did not help me at all. And of course, we know why, because I'm pelvic floor driven. Total waste of money and time. Hello, Aloria. I have IC and really appreciate the webinar. I'm in a lot of pain daily. Oh, honey, I'm sorry. Do we know where your pain's coming from? Is it coming from your bladder wall or your pelvic floor? Do we know? Or, okay. So here, let me give you a story from this week. So okay, Victoria says, that's why it stopped working. Your pelvic floor driven. Exactly. And the placebo effect is real. And the reality is it's a rescue installation numbs the bladder wall. And so you're going to feel better when they numb your bladder wall, but it's just not going to fix anything. The pelvic floor, if your pain is coming from your pelvic floor or if that bladder wall pain is being driven by ischemia caused by tight pelvic floor muscles, the fix for that is to reverse the ischemia by relaxing the muscles with physical therapy. So Aloria is having bladder wall and pelvic floor pain. Okay, so let me give you a real story of a patient I worked with, I think on Thursday. Might have been Thursday, might have been Friday. So really intense pain. Symptoms for at least a decade. Absolutely know she has tight pelvic floor muscles, had been diagnosed for sure with tight pelvic floor muscles. But she was also having, as she described, really severe bladder wall pain, and she could not eat any fruit at all. She couldn't eat pears. She couldn't eat apples. Pears, low acid, blueberries, low acid. Many IC patients can eat low acid fruits. And I asked her, I said, well, does pre-leaf help? And she said, no. So here's a patient with a stunningly sensitive bladder wall. And I said to her, okay, that concerns me. And that I would assume that would concern you too, because that's really extreme bladder wall sensitivity. So what did they see when they looked in your bladder? And her answer was, well, I won't let them look. I'm afraid I won't let them look in my bladder. And I said to her, now wait a second. Are you telling me you've had very severe pain like this for 10 years and you've never let anybody look in your bladder? And she said, no, I'm too afraid. I'm afraid they're going to hurt something. And I said to her, now listen, there's a fundamental flaw with your approach here. You are forcing the doctor to guess. And that's not reasonable. You're suffering. I mean, if my policy is if I'm in pain for 6 months and I'm crying in pain, I want somebody to look. I don't care if my urethra is going to get sore. Please look and tell me why I'm in pain. And she's not the only one. We see this all the time, especially, God forbid, she had come onto Facebook and she had read scary things about people who'd had hydrodistensions. And she's like, I don't want to do that. And I had to explain to her, well, listen, 10 years ago, they used to do high pressure hydrodistensions that hurt more, but they don't do that anymore. Today, they do low pressure stuff, and it's not going to hurt as much. And really, the only thing that's probably going to hurt is your urethra, and that should go away in a day or two. But at some point in time, you got to let somebody look in your bladder because this is persisting way, way, way too long. And I shared the story of another woman just like her who it turned out, I mean, she suffered terribly for 10 years. And when she finally let them look in, she had a bladder stone. She had a giant kidney stone that was very sharp, cutting her bladder wall all day. It's floating into urine. When her bladder was full, it would go to the top. When her bladder was empty, every time she peed, it went to the bottom, scratching her bladder all day. So when they broke up and they got rid of the bladder stone, she's cured. She suffered for 10 years with pain because she was too afraid to let somebody look in her bladder. So it's, we need to take the guesswork out of this. Now we need facts. What is the health of your bladder, if any? What is the health of your muscles, if any? What are the health of the nerves, if any? What is the health of your skin? Those are the dominant things that we're going to look at. And so I think I was able to, she was getting worse. And it's like, honey, you could have a Hunner's lesion. And if you have a Hunner's lesion, don't you want that treated? Or are you just going to live with pain for the rest of your life? Now Laura says, I also have not had the cystoscopy. You've been too scared. Okay. So what's it going to take? I mean, you've tried bladder therapies. You say you tried the bladder installations. They helped a little. You're on 25 milligrams of amitriptyline. It's helped a little, but you still have flares. So it's fair to say that you're chasing the symptoms. You're not necessarily looking for and trying to identify the underlying cause to fix the underlying cause. Listen, I've had 3 cystoscopies. If I were streaming right now and my urologist walked in and said, Jill, I want to do a cystoscopy and look at your bladder, I'd do it live on stream. I am not worried about that at all. I've had 3. Doesn't scare me at all. And a flare doesn't scare me at all either, because I know what's causing my flares now, which is my pelvic floor muscle. You got to take the fear out of it and just say, okay, I'm not going to be afraid of this. I'm going to get some productive information here. Because if you have that cystoscopy and your bladder is perfectly healthy, that is fantastic news. That is proof that you've got a good, healthy bladder, and that means your pelvic floor is probably driving all of this. In contrast, if they look in your bladder and they see a lot of inflammation and they see a lot of Hunner's lesions, then now we know we got to change direction. We got to work on the lesions instead. But you can't make those decisions until you let them look. It's important to let them look, in my opinion. I don't like guessing. I like facts. I just want to know what they see. Give me a picture. Show it to me. Johanna says they work for 2 or 3 days and the bladder goes back to being stubborn. But that's the point, honey. That's why it's a rescue installation. It numbs the nerves for 2 or 3 days. It calms the tissue for 2 or 3 days, but then it wears off. And so that is a perfect example of chasing the symptom. It's not fixing anything, but it's giving you a couple of days of discomfort. And the reality here is it's important to have a couple of days of discomfort, of comfort, not discomfort. So that you can see that you can feel better. When you're in the midst of a chronically painful condition, and you're in pain every day, it's scary as hell. It's so scary. And you feel like, my first year was horrific. I had no help for my pain. And then finally at the ER, they gave me a pain shot and it turned everything off. My frequency was gone. My urgency was gone. My pain was gone. And I was like, wait, you could have turned this, you can turn this off? What? It was shocking to me that you could just turn it off, with a pain med. And for me to have a relief from that pain for a period of time was critical to my survival and my emotional health. But then I had to get down to the dirty work, because you're not going to, listen, you don't just treat this with pain meds for the rest of your life. That's not going to fix anything. Now we got to do the hard work and try to figure out what's causing the pain in the first place. Is it an untreated Hunner's lesion? Is it a very tight pelvic floor? Is it a fibroid tumor pushing on your bladder? Is it endometriosis attached to your bladder? Is it a really bad bladder infection? You don't just give up and say, I'm just going to take, I had somebody call me like 2 weeks ago. It's like, I only want pain meds. And I chewed her out. I was like, hey man, I understand why you want pain meds. I wanted pain meds. But you can't live on pain meds. We got to fix it. We got to find it and fix it. Have you had your pelvic floor assessment? No. Has anybody looked in your bladder? No. Well, what the hell are you waiting for? Come on. Let's see if we can figure this out. Because pelvic floor physical therapy is really successful. Victoria said, I got the low pressure one and it went away in a day or two. Glad I got it. Exactly. Cookie said, thank you, Jill, for your help and for your link. Do I need to tell my urologist about it if I can take Bladder Builder? Do I need his permission? Honey, it's over the counter. You don't have to have a prescription for it. You can just go on over to the IC Network website, click on our shop, and it's right on the front page. And for anybody late who came in, these are the new bottles. So this is the old bottle. This is the new bottle. And same stuff. They didn't change anything. They just changed the bottle because they're trying to make all the bottles match stylistically. I love it. I think it's great. We just got it in yesterday, as a matter of fact. Lori said, my pelvic floor physical therapist wants me to do reverse Kegels, and I still can't do it right. Oh, you know, Lori, you are so right. It is really hard to have somebody describe to you how to relax your pelvic floor. And for me, my physical therapist said, it's like a rosebud opening. It's like, so the best way that I can describe it is a Kegel, a normal Kegel focuses on tightening, right? So, you contract your pelvic floor, you hold it for a couple seconds, and then you release. And oftentimes when you go to a physical therapist for the first time, when they're doing their pelvic exam, they will have a finger in your vagina or your rectum, and they will ask you to do a Kegel and they'll have you do 3 or 4 in a row because they're just feeling what your muscles are doing. And I know for me, it was really easy for me to tighten. It was really hard for me to relax. And so I did like 2 or 3 normal Kegels, and then all of a sudden I really couldn't do it. I mean, I really had trouble relaxing. And she's like, okay, now I know what we're dealing with. We're dealing with weak muscles. Underneath the tight muscles are weak muscles. Muscles get tight because they're weak. They have a job to do, but they're weak. So they have to overcompensate. So they get tight to do their normal job that they would normally do. Okay, so anyway, Kegel, you focus on the tightening. A reverse Kegel, you focus on the relaxing. So it's a quick tighten for a second, and then it's like 4 seconds of relaxing, like I just did it while I was talking. And you can, think about a tight rosebud that kind of opens like that. I just focus on the relaxation part when I'm doing it. Robbie says, does anybody know a really good doctor in Gainesville, Florida? I have IC with 500 lesions, lichen sclerosis, and you recently moved to Florida. Robbie, if you go over to the IC network, we have a Find a Doctor database, and I just did that for somebody that was kind of in the Tampa area, and we found 4 or 5 urology clinics. So go over to icnetwork.org and then go to the interstitial cystitis pull down menu, and you'll see Find a Doctor. Go there, put in your zip code, and it might take a minute to load. You got to be patient. And then you just have to go through the listings, and you might be able to find a doctor that way. It's very, very hard to keep these lists updated, my friends. It's very hard to keep them updated. So clinics close, people move. It's one of the things that on the IC network that I don't like doing, because it's a no-win. For every record we update, we lose a record, but they don't call us and tell us that they've moved. So it's very inconsistent. Lori said, I have lichens. Dr. Jill Kraft is a lichens expert in Florida. Great thing to share. Thank you for sharing that. Much appreciated. Much appreciated. All right, guys, I am here as long as you have questions for me. So let me tell you what I'm working on right now. We're doing a lot of updates on websites. So my next project is, I've got a bunch more videos to upload to our free IC 101 masterclass on different types of flares. And we're going to be massively editing our store and our website, removing old information. I mean, the IC Network website is the largest archive of IC information in the world, but there's a lot of old stuff from 20 years ago that I just have to delete. So it's, you know, it's a work in progress. It's a real work in progress. I want to encourage you, please, if you're looking for information about IC, do not rely on TikTok. Do not rely on Facebook. You know, go into the Facebook groups. Everybody universally agrees at that professional level that Facebook probably does far more harm than good for IC patients. And I'm going to agree with it. And the reason why I do this meeting on Facebook and YouTube is to be a calm port in the storm with really good information. You know, because this is my job, and I've been doing this for 30 years, and I'm a scientist. So I've done my research, and I know what to say, you know. But there are a lot of people on Facebook, people sharing their own stories that might have no relationship to yours. So we've been having a lot of meetings recently with some of the big stakeholders in this about how can we improve social media and IC, and it's brutal. It's really, really brutal. And I have to tell you, I don't read. The only social media I read is Twitter, and it drives me bonkers. I don't spend, other than doing these meetings and looking at our feed. You know, we have a lot of. I have a fabulous consultant who does some social media education for us, and so we have a lot of posts and stuff. But I don't spend time in IC groups on Facebook. I'm just like, I've done that. My focus entirely is one-on-one work with patients. And I am happy to talk with anybody on the phone, on Zoom, on WhatsApp. You are welcome to call me at any time. It's free. If you want to do a coachings are $50, but most of the time it's free anyway. And I'm perfectly happy to work with people that way. But social media is just a knife in the heart of the IC movement at this point in time, I think. Nav said, do you believe in neuroplastic pain? Do you believe that IC can come from a dysregulated nervous system? Absolutely, honey. That's a phenotype. 40%, we now estimate that 40% of IC patients have nervous system dysregulation. We call it widespread pain or chronic overlapping pain condition. So these are the patients who have IC, IBS, vulvodynia, TMJ, fibromyalgia, migraines, and we have very, very clear research that has identified the underlying cause for all of this relationship, and that is the central nervous system, and a central nervous system stuck in a constant state of fight or flight. And the Central Nervous System studies done by the Chronic Pain Research Alliance, they're the ones who really identified that patients who have these multiple pain conditions have a brain that is literally stuck in fight or flight, that the amygdala, which is the command and control center for fight or flight, is always on, and it's not supposed to be always on. Fight or flight is normally short term. You know, if you see a threat, of course you're going to go into fight or flight, but when the threat's gone, the fight or flight is supposed to turn off, and the parasympathetic nervous system is supposed to take back charge of the brain, calm everything down, lower your heart rate, lower your blood pressure, relax your muscle. That's not happening in patients with chronic overlapping pain conditions. We're literally stuck up in fight or flight. And so we are absolutely doing certain strategies to bring that brain out of fight or flight, to reduce that anxiety, because of course anxiety goes part and parcel with us. This is my phenotype. I have two phenotypes. I'm pelvic floor driven and central sensitization. And the thing that really, and I'm minus trauma driven. I was attacked by a rapist murderer when I was in 4th grade. You know, year I went away to college, he raped and murdered my neighbor. Didn't leave my home without fear for a decade. Very common. The childhood trauma is very common. My situation was very rare, but usually it's growing up in the home of an alcoholic or abusive home. So therapeutically, we have got to calm the central nervous system and bring that central nervous system out of fight or flight. As long as it's in fight or flight, it's going to magnify everything. It's going to intensify pain. It's how the brain responds to a threat. EMDR therapy has become fabulous. I've done EMDR therapy and did really well with it. Johanna, I don't know. They just told me they were going to do it. As soon as I find out, I'll let you know. I'll be sending out a blast email to our members. We have about 35,000 people who read our free newsletter. And I'll be sending it out that way. But you can just call too. You know what? Let me check my email. Maybe they got back to me already. Hold on. If they're working on the weekend. Oh, so much email. I'm getting so tired of email too. Let me see, because I literally sent them an email on, here it is, on the 6th. Yeah, no response yet. They just told me it was coming. Joanna says she has IBS and chronic constipation. So, Johanna, the website that really helped me with my IBS was a website called helpforibs.com, done by Heather Von Voris. Heather Von Voris is the author of First Year IBS. And she was the one who explained it to me so that it finally made sense. Because what she basically said is that the nerves lining the bowel have become very sensitive, and they're very easy to provoke. And so when you provoke the nerve, you can cause diarrhea. And if you provoke the nerve so badly, the nerve basically stops, and then you're dealing with the constipation. And so the first thing she taught me was the difference between a soluble fiber and an insoluble fiber. An insoluble fiber is a fiber that does not dissolve in water. It's rough and scratchy. So granola is a perfect example of an insoluble fiber, and lettuce is a perfect example of an insoluble fiber. And the problem is because the nerves in the bowel are so sensitive, when that rough texture starts moving through the bowel, it triggers the nerves. It's irritating. Whereas a soluble fiber is a fiber that dissolves in water and it's smooth. It's still a good fiber. It's a great fiber, but it's not provocative. So an example of a soluble fiber is acacia fiber, or eating green peas, or like navy beans. And for me, what used to drive me crazy in my 20s is because I had IBS-C and D. I would rotate between them. I would go out with my girlfriends to lunch, and we'd all get a chef salad or a Cobb salad or something like that. 30 minutes later, I'd be in the bathroom with horrific diarrhea, like really bad cramping. This happened many, many times. I'd be on a date, and God forbid I ate salad first. It would just ruin the date. Absolutely ruin the day. I'd have to go home and I'd have to sit in the toilet for 2 hours while I was having this diarrhea. And so what she says is you never ever start a meal with an insoluble fiber. Like the first thing that goes into your mouth has to be something soluble. So if you're going to have a salad, don't have it before you eat. Have it at the end of the meal. Like I eat a ton of salad, but I don't start with salad. I end with salad. And the other thing she said is, when you're starting with a soluble fiber, start with a dinner roll or some rice or potato, something, or, something that's soft and gentle. And then I was telling her, I was saying, listen, I can have a bowel movement if I eat a lot of fiber cereal. The problem is they're painful. And she said, yeah, of course they're painful. They're painful because you're eating a lot of rough, hard textures. It's tweaking the nerves in your bowel. You got to change it up. Don't do the insoluble fibers that way. You got to do a soluble fiber. And so I started doing like a cream of rice cereal in the morning. That was great. No problems at all. So I would go over to Help for IBS. And she created a product line, Heather's Tummy Fiber, which we sell. I use it myself. It's fabulous. But go into some of her educational content. Her educational content's really, really good. Nav said, I just had a bladder hydrodistension. They said my bladder is very normal, but you still feel burning pain and have constipation. Okay, so Nav, you have a healthy bladder. That's great. Celebrate it. What that means then is something else is driving your symptoms. You said you had tight pelvic floor muscles. Well, tight pelvic floor muscles can cause constipation. Tight pelvic floor muscles absolutely cause burning. Muscles that are working hard produce lactic acid, and that burns. And you're doing Lyrica for nerve pain. Okay, so you got to be careful with Lyrica and Cymbalta. They're perfectly fine meds, but they're really hard to get off of. So they can cause what we call a discontinuation syndrome. A discontinuation syndrome means if you stop it suddenly, you basically go through withdrawal. And the withdrawal can be really difficult. And so if you're ever going to go off the Lyrica, you have to work with your doctor to go off gradually, okay? You can't cold turkey that. Or talk to your pharmacist. Johanna says, I take Linzess and Miralax. Okay. Johanna, just remember, for you to have healthy bowel movements, you got to have 20 grams of fiber a day. For 20 to 25 grams of fiber a day for a woman, 25 to 30 grams of fiber a day for a man. And so literally for me, that one big serving of peas, whenever I'm feeling a little obstructed, does wonder. When I go to the salad bar, I basically eat chicken, grilled veggies, and salad. And then a slice or two of sourdough bread. That's like my diet right now. When I make my salad at the salad bar, I do shredded carrots, I do peas, I do corn, I do garbanzo beans, I do cucumber, and I do artichoke hearts. And I've learned Never to do that and eat split pea soup at the same time, because you will give yourself a colon cleanse. But having a couple of bites of peas and garbanzo beans in your salad works wonders for getting that fiber content up. Robbie says, my husband gets that kind of diarrhea from preservatives they spray in lettuce. No salads when we. Yeah, I was exactly the same way. And also Chinese food. I got to tell you, I was working in San Francisco for a year before I went back to grad school. And I was working for the feds. I was a black lung specialist for Social Security disability, believe it or not. That's what I did for a year. And I had to take a bus 90 minutes both ways to get to San Francisco. Well, anyway, the entire team went out for Chinese food. Oh, it's horrific. And I had already done the whole salad diarrhea thing. And so we go to this Chinese restaurant. I'm like looking at the menu going, oh my God, what can I eat? What can I eat? Because I had to take a bus ride home. And the buses did not have bathrooms. And so I thought, you know what? I'll just get the wonton soup. Huge mistake. Oh my God. I had explosive diarrhea for hours afterwards. I mean, it was like Epsom salt. And I mean, we ate at like 12. I was in the bathroom from like 1 to 5. I kept running out of the room, going to the bathroom. And they were like, are you okay? And it's like, yeah, the food got me. My goal was to be empty so that I could ride the bus home. And I ended up putting on because there was no bathroom on the freaking bus. Man, the things that happen to us, right? And all I remember is I just put on 2 menstrual pads and prayed, ran to the bus stop, got on the bus, and just prayed all the way home. And I was empty, thank God. So you can tell your husband he's not alone. But that's also what would be interesting is, does that happen when he eats lettuce at home? If that happens when he eats lettuce at home, he's got the same nerve sensitive bowel. So I literally don't eat lettuce anymore. And I have a ton of salad. I just don't add leafy greens to it. And I'm way better for it. I just have to say, people think I'm crazy, but I'm telling you, I'm fine. Gail said, do you recommend sacral nerve stimulation? I'm scheduled for one from Axonic soon. I've tried everything else. Oh, Gail. Girl. Okay. The answer is the window for nerve stimulation has gotten very, very small now that we're phenotyping. So what is a phenotype? A phenotype is a patient group. We're not all the same, right? So the IC patient population is what we call heterogeneous. It's very diverse. So we've got patients with Hunner's lesions. We've got patients with pelvic floor dysfunction. We got patients with estrogen atrophy. We got patients with muscle squeezing nerves, pudendal neuralgia. We've got patients with widespread pain. We have a lot of different patient groups now, each with their own treatments based upon the group they're in. So when InterStim and neuromodulation was approved, 25 years ago, they were doing it on the assumption that we all had an incurable bladder disease, and that one way of calming the bladder down was to kind of re-regulate the nerves. There was kind of an assumption that one of the reasons we struggled is that our nervous system was behaving abnormally. Therefore, if you apply a gentle electric current to it and try to normalize the nerve, maybe just maybe that'll help the bladder. And I will tell you that it was invented at UC San Francisco, where I was a patient. I'm intimately familiar with neuromodulation, not only because I was a patient there, but also I ran the support group in the San Francisco Bay Area, Northern California, where all those early patients came. So we have a lot of data early on from that. So the question then is, what phenotype is going to respond the best to neuromodulation? So is neuromodulation going to help a Hunner's lesion heal? No. Especially if that lesion is caused by a virus, then we got to do an antiviral. We're not going to stimulate nerves. We're going to find the virus and treat the virus. If that lesion is caused by a broken ligament, no. Nerve stimulation is not going to do a damn thing for that. Is nerve stimulation going to repair a damaged bladder wall? No. Is nerve stimulation going to help a new whole bladder wall grow from estrogen atrophy, for example? The answer is no. I don't see how that would happen. Is neuromodulation going to help tight pelvic floor muscles? Not as well as physical therapy. Muscles respond best to hands-on physical therapy. Is neuromodulation going to help pudendal neuralgia, where you have a muscle squeezing a nerve? Normally what we're going to do is figure out where the nerve is being squeezed and release that, and then we're going to try to calm that nerve down. So maybe there's a little application there. Is neuromodulation going to help bring a brain out of fight or flight? I'm not aware of any data that says that it would. So, and you know who talked about that? Here, hold on a sec. Curtis Nickel, again, the top researcher up in Canada, and the U.S. government paid him. I mean, he's really, 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 really good. So I'm not so arrogant as to say only American researchers are good. Listen, foreign researchers are great. Right now, some of the best research is being done in China. So anyway, Curtis Nickel, right before he retired, proposed 9 phenotypes. And he gave his recipes for treatment. And so let me just see how he mentioned it. So did he mention it for inflammatory IC Hunner's lesion? No. Infection mediated? No. Neurogenic hypersensitivity, widespread pain? No. Multiple allergies? No. Pelvic floor pain? No. Primary storage symptom syndrome. Some IC patients run to the restroom to reduce pain. Their frequency and urgency is driven by avoiding the pain caused by bladder filling. Dr. Nickel believes these patients could benefit from an antimuscarinic medication if the pain has been controlled, so like mirabegron. He believes that bladder training is essential to bladder capacity, and then this is a direct quote. As a last resort, Botox A can provide short-term symptom relief, though it carries a risk of urinary retention. And he said, sacral neuromodulation has helped some patients, but Dr. Nickel did not believe that it significantly improved pain. And in fact, here in the United States, the FDA approval specifically excludes pain. So the only thing he mentioned, sacral neuromodulation, was as a last resort if Botox didn't work. You start with the meds, like mirabegron, along with bladder training. Then it's Botox A, and then if that didn't work, sacral neuromodulation. And let me give you the link to that so that you can read that yourself. Now, the other thing to be aware of with anytime you have surgical neuromodulation is that the risk of side effects are real. Lots of adverse events, especially with the inner stem system. The system that you're having does not have quite as many adverse events, axonics, but let's look at that. So hold on a sec. Let me just go to the FDA database for medical devices, and let's see what they're saying about, what doctors are saying about axonics adverse events, because you gotta be informed what the risks are. And marketing materials often make it sound like it's easy, but you get the truth when you actually look at the FDA information. So I'm searching for axonics, and I'm going to search from, I'm going to search from 2024 to today. Let's do a 2-year search. Let's see what comes up. 500 adverse events. So the last one was filed on February 27th. There's a 5. Okay. So, I want to share my screen so you can just see what I've done. So hold on a sec. Let me back it up. Okay. For YouTube, you're not going to see this, but Facebook is going to see this. So hold tight. I'm going to drop that down, and I'm going to drop this down. All right. So hold on one sec. All right. So you on Facebook, you should now be able to see my desktop with the owl and then lots of files that I have open because I tend to be a wee bit disorganized. I do a lot of screenshotting. Okay, so this is the MOD database, Manufacturer and User Facility Device Experience. And this is where you can search for any adverse events associated with any medical devices, from pacemakers to neuromodulators. So what I've done is I put in axonics right here, and my search period is January 1st, 24 to February 27th, 26. And I'm going to click. So I'm not doing go to simple search. I'm clicking search. Okay. So now we have 500 reports of adverse events with axonics. So let's look at a couple of them. Here's the first one. Serious injury, medical device. It was a migration. So let's look at this. It was reported that the patient experienced back spasms that are primary on their left side and spread across the back just below the shoulder blade. The patient experiences the pain only when bending and rotating. The patient has had a motor vehicle accident years ago where they had disc trouble in the same area, but their physician has confirmed that there are no issues with the disc. The patient asked if this could be from their device on their right side. The patient also noted that their battery is moving in the pocket. Their symptoms seem to be well controlled and they've not had any falls. The patient is recently recovering from a valve replacement. All right. The patient had turned off their device and is taking tramadol and Flexeril with no relief. The patient was advised leaving their device off for a couple of weeks to rule out pain from the device and also due to wearing the Holter monitor. Because we have at least one report of a heart complication where the heart begins to beat in time with the generator. Okay, so this is a formal report of a serious injury from axonics. Let's go to the next one. So we have 1, 2, 3, 4, 5 that were filed on the 27th. Serious injury. Okay, this is just a patient who said the device stopped working. Okay, so I don't know how they qualify that as a serious injury, but anyway, let's go to the third one. It was reported, so this is serious injury. It was reported the patient had surgery to revise the neurostimulator and tined lead. The revision was due to a lack of efficacy. During the revision, the original lead was tested for motor responsive. After the patient was implanted with a neurostimulator and tined lead, good motor response was present. the patient is doing okay post-revision. Okay. So that's a little vague because it's not saying why they had surgery. I mean, obviously there was a problem when they had to go in and revise it. So there must have been pain or discomfort associated. Let's go to the fourth one. Here's somebody, adverse event, urinary frequency discomfort. It's reported that the patient felt like the stimulation made their frequency worse. The patient also mentioned discomfort from the lead placement and opted to have an early lead pull. Okay. We'll do the last one from the 27th. No, this is important. It was reported that a patient experienced pain from their left hip and down their leg. Patient pain got more severe and they went to the ER. The ER prescribed oxycodone. The cause of the pain was undetermined. The patient increased their stimulation settings. The patient also complained of increasing symptoms, but not worse. The representative suggested turning off stimulation. The event is ongoing. So I would encourage you to Google MOD, come to this database, and look through a bunch of these. So here's one. This is common. It was reported that the neurostimulant time lead replaced. The patient fell and X-ray confirmed the lead had moved. A revision procedure was performed as a result of this event. And just so you know, over on the IC Network website, if you go to our IC Information Center, go down to treatment, and then go down to neuromodulation, we talk about the two different types of neuromodulation, the post-tibial nerve stimulation, which does not require surgery, and the sacral or pudendal nerve, which is what they're suggesting. But I have a list of questions here. You should ask your doctor before you have it done. You want an experienced doctor. You don't want somebody doing this new for the first time because this is involving nerves around the spinal cord. So you're going to ask them what training they've had for the care and maintenance of the device. What complications have you experienced in patients during both the trial and implant? Were those complications resolved? How often have your patients required additional surgeries? How often have your patients required a device to be removed? When removing the device, how have you encountered any difficulties? I mean, there are just a lot of questions here that you want to ask your doctor. Understand that neuromodulation requires a lot of monitoring. It's not like you're one and done. You're going to go on with the rest of your life. The doctor has to inspect it. The company has to inspect it, make sure it's working properly, etc., etc. All right, let me go back here. All right, now you're back to me. And hold on one sec. All right. You can tell we've had that question over and over again. All right, hold on. I'm trying to find I minimized my YouTube. I got to find it. Is that it? There it is. All right. Victoria said, what is the best supplement to take to replace Elmeron? I believe it's Bladder Builder, but I have written a guide, and let me get you the link for that guide. So hold on a sec, because this has been going on for many years, patients transitioning off of Elmeron. Because number one, because it's just got too expensive. I mean, that was the brutal reality. So hold on, let me get you that link. There you go. Well, we've been going now for three hours. So let me do this. I mean, I think we're pretty much done. I think my voice is pretty much done. And besides, it's daylight savings time. If you can get outside and enjoy the sunshine a little bit, do it. That's what I'm going to go do. So let me do a last call for questions. Last call for questions. Otherwise, I will see you next week. And you're welcome to give the IC Network a call. Please think about becoming a subscriber to the IC Network. We have a great magazine called the IC Optimist where we do our best work. $25 a year. Can't beat it. Gotta bring your knowledge level up, especially if you're not responding to therapy. And anybody out there, if you're struggling with wicked flares, feel free to call. It's free. 800 number right at the top of the page. You know, and I'm happy to talk to anybody. I'm happy. Now, if you want to do a really deep dive into your case, I'm going to have you sign up for a coaching session. Oh, Katie was asking about Jim Tessa. Thank you, Johanna. Here, hold on. Let me see if I can find that. Does Jim Tessa work for urgency, frequency, and or bladder pressure? You know, it's not a recommended treatment for IC, but let me look at it again. I mean, it's not in our guidelines. It's an overactive bladder medicine. Oh, it's Virabigron, or Vibigron. So it's primarily used for incontinence, urgency, and frequency. It relaxes bladder muscles to increase bladder capacity. Common side effects include headache, nausea, diarrhea. One of the things that sometimes happens with these meds, and it happened to me, but it was a different med, and I'm not sure if the method of action is the same. They gave me an overactive bladder medicine called ditropan, and ditropan calms bladder spasms. So it relaxes the muscles. And if you're having active spasms, bladder spasms are miserable. And generally they happen as the last couple of drops of urine are coming out of your urethra, and then you get a violent spasm that kind of shoots up your back, and you're kind of frozen on the toilet for a couple of minutes until it relaxes. That's how I experienced my bladder spasms. Ditropan turned off bladder spasms in 20 minutes. It's a smooth muscle relaxant. The problem is that if you take it for longer periods of time, it just kind of deadens the muscle. And so I know that I was on it for like 3 months, and when I got to that last pint, I could barely pee. I just didn't have an urge to pee. And I just took it way, way, way too long, even though the doctors kind of wanted to do it. So the research, it looks like it's FDA approved for frequency, urgency, incontinence. I mean, you won't know until you try it. Is it going to help bladder pressure? I have no idea. I would just be attentive to the potential side effects. I mean, what are the side effects? Headache, nausea, diarrhea, constipation, UTIs, can cause severe allergic reactions, angioedema, or what I experienced, urinary retention. The retail price for 30 tablets is $617. Yikes. Robbie says her bladder spasm lasts about 20 minutes. Yeah, that's a long one. So again, in that circumstance, doing an antispasmodic makes total sense. But do you have to take it when you're not having spasms? And the answer is, I don't think so. But just has to be a discussion between you and your doctor. All righty. All right, my friends, I'm going to say goodbye. I will see you again next week. And just know, in 2 weeks, okay, I'm a K-pop girl. I love K-pop. I just do. I'm a K-pop grandma. BTS is having their live concert on Netflix on Friday night, Saturday morning at 4 a.m. on the 21st. I'm going to be watching that because I love this group. So hopefully I'll be in good condition in 2 weeks. We'll see. You never know what's going to happen. Anyway, I'm going to say goodbye. I love BTS. I just think they're a fabulous group. All right. Bye, YouTube.